liver fatty disease. And this is a risk factor for liver and GIT and other cancers. Let's see what is being told to us. Over to Professor Sanyal.
With your permission, sir, I believe Dr. Singhal actually is waiting to board a flight and has requested if he might go first. I'm completely fine with that. But Ashwani, do you want to make your
Yeah,
So
request?
that's fine.
I actually reached out earlier, and thank you, Arun, for being so gracious and letting me present first.
Absolutely.
Thank you.
Please carry on.
Okay, so I'm going to share my slides here. Can everybody see my slides?
Yeah, that's fine.
Yes.
Okay, first of all, I want to thank the NAMS for selecting me for this honor, and especially this double honor because on the same platform, some of the giants of the field in hepatology and other parts of medicine here. So when I got this invitation, I kind of was thinking what to do and what to present. Do I give a talk on alcohol-associated liver disease or porphyria? Or do I just say, as the title says, academics and research achievements? So I thought, putting that into perspective, let me tell my journey, which is little different from several of the people even from India or who have been selected for this honor. So I'll just start, and hopefully you will like what I'm going to talk about in the next 10 minutes. So, although currently I'm a professor of medicine at the University of Louisville in Kentucky, USA, my roots are back to India, where I started my MBBS and then MD medicine from PGI Chandigarh, and then did a DN Gastro from GB Pant. And then waited for 3 years to get an academic position where I actually my interest was, but by default went into practice, which I did for about 7-8 years. And my heart was always in academics, despite being in practice. So one of the examples which we did, being in practice and then doing academics at the same time, was this book. In 1996, we did a national conference with Dr. Sareen. And this culminated into deliberations of experts into a book, which was released on the day of the conference and became an instant hit. And within a couple of weeks, sold 3,000 copies, actually. And that encouraged us to do another meeting in 2000, a little bit more wider at an international level, where 14 faculty from international world were invited. And this was a little more on management also, because by that time we had lamivudine in India coming for hepatitis B. And then started my journey to USA, because I convinced myself this is what I want to do. And I got an opportunity. And part of it was retraining myself. But two other things which I did, being in US in the first 6 or 7 years after I started, was Master's in Clinical Science in Galveston as a part of my GI Fellowship program, and 2 Transplant Hepatology Fellowship in Mayo Clinic, Rochester, Minnesota, which was awarded to me by ASLD as a Sharing Plow Award. And that led into, and during that time, when I was a fellow at Mayo Clinic, I tasted first time success of a high impact factor paper in hepatology on liver transplant outcomes of alcoholic hepatitis, similar to alcoholic cirrhosis. And at the same time point, we all know that French data came out in New England Journal, and these 2 studies, our being retrospective, their being prospective, laid foundation for guidance on early liver transplant in alcohol-associated liver disease and alcoholic hepatitis. So proud of that achievement. And then in 2012, after I finished my fellowship, I started my first faculty position, and American College of Gastroenterology kick-started my research career with a faculty development award. and within a year got a R21 from NIH. And in both these awards, we studied peripheral blood sample PBMCs, studying on this seahorse plate, where you could have the opportunity to inject enhancers or inhibitors of mitochondrial respiration of these cells, leading to, after 2-3 hours of experiment, a bioenergetics profile of an individual. And our aim was to see whether that bioenergetics profile could separate patients with alcoholic hepatitis versus those without. And also, could this be a biomarker for predicting response to corticosteroids in patients who are having alcoholic hepatitis? And could this biomarker separate those patients even before giving corticosteroids to them? So I think that was one of the other things which we did in research career of mine. Let me switch gears a little back to 2009 when I was doing a GI fellowship. I was looking for a master's thesis because this was a degree program, so I had to have a thesis done. And we were talking about mentee-mentor, and I got a good mentor there, Carl Anderson at UTMB, and I jump-started into this randomized control trial, which was ongoing at that time, comparing hydroxychloroquine to phlebotomy in the treatment of a rare disease, porphyria cutanea tarda. And this was published not only in the leading journal of AGA, the Clinical Gastroenterology Hepatology, but also laid foundation for the clinical trial designs for porphyria cutanea tarda field and guidance and guidelines for this disease down the line, which have been published in the last 10 or 15 years. And this also led me to be the site PI of the Porphyria Consortium of 6 nationally recognized centers on porphyria, UAB in Birmingham, Alabama being part of that. And I was site PI or MPI for 2 years before I moved out of UAB. Well, on this slide, I'm highlighting some of the papers or few of our papers, which are not only high impact, but also change the way we practice and treat our patients. This is a paper from Journal of Hepatology, this one recently from Hepatology. This is from Gastroenterology. And this led us to an invitation from one of the high impact JAMA or Journal of American Medical Association to write a review article on alcohol-associated liver disease. And recently, which Arun was also part of, is this designing clinical trials, culmination coming from a workshop between FDA and NIH on position paper in Nature, how to design clinical trials in alcohol-associated liver disease patients. And last year, I was recruited to all this work over the last 10 or 12 years in the field of alcohol-associated liver disease. It got me recruited to one of the NIH-funded research centers in USA at the Louisville, Kentucky. This center has been funded for this 25 years by a P50 program. And within a year of joining this center, I got my own funding. Recently, we got funded for the third cycle, I think, from the U mechanism on the consortium of alcoholic hepatitis in the USA, which Arun is part of, Naga is part of, and now I'm proud to be part of that as a MPI or a site PI of this consortium. So any academic career has 3 pillars, I think we all know: research, service, and teaching. So now I'm going to talk about my service assignments. Other than patient care, I'm proud to be associated with all the 3 major organizations in America. Currently at ASLD, I advise on the Special Interest Group Task Force. After spending 2 years of stint as a chair, where I ran the alcohol-associated liver disease SIG for 2 years. At the AGA, I'm chairing the liver and biliary section since beginning of this year, and I have 1 more year to go. And I think I'm most proud of my association with ACG since 2018, when we wrote these guidelines on alcoholic liver disease, followed by 2 years later on disorders of mesenteric and hepatic circulation, and early this year, a revised guidelines on alcohol-associated liver disease, and one on nutrition and liver disease is coming in press now in the first quarter of next year. Their University of Louisville, Craig McLean is also part of. So over the last 5 or 6 years, we have also been involved in various journals as a focused issue on alcohol-associated liver disease, starting translational gastroenterology hepatology in 2019, metabolism, target organ damage, another issue, in nasal journal, Journal of Clinical Experimental Hepatology, this year clinics in liver disease, and one in seminars in liver disease in press coming next year, again a focused issue on metabolic liver diseases. Coming to teaching, I've been fortunate to get about total of 82 mentees I counted actually, not only from USA but other parts of Asia because of my association there. And 5 of them actually went on to win awards, 3 of them as emerging scholars at ASLD. And I've been involved locally, regionally, nationally, and internationally, giving educational talks on different subjects in hepatology. And I've been very fortunate to be awarded and recognized for my work for service, for example, by ACG, by Edgar Etchker Award when I visited University of Iowa to give a research grand round in GI. My research award as a recognition, highly cited author from Journal of Clinical Translation of Hepatology, and 2 years ago, recognized as a mentor and a teacher by medical students of University of South Dakota, where I spent few years. And it could not have been possible, whatever little I have achieved, nothing compared to the giants over here, the other 4 giants. But whatever little I achieved, coming at the age of 45, starting as an intern, whatever little I've achieved, I think could not be possible without by mentors on the way. And I would start the mentors coming from India, Dr. Dilabri and Dr. Chawla during my MD medicine training, where they showed me how to enjoy hepatology, followed by Dr. Anand and Dr. Sarin from GB Panth, where I spent my DM gastroenterology. And then in America, I would say Mark Poston and Scott Friedman during my residency, Don Powell during my GI fellowship, and Vijay Shah, whom I currently also associate with because we have common interest, and he's also part of the consortium of alcoholic hepatitis from Mayo Clinic in USA. And obviously my family, I have my lovely wife, 2 children and 2 grandchildren now, 4 and 2. So I will stop here and thank again for patient listening on my journey, which I hope you liked, and I'll be happy to take questions.
Thank you very much, Professor Singhal. I think National Academy is honored to honor you with FAMS. Such a elite, and I think you are an example for anyone here. We were just discussing before this a mentor-mentee session, and you are a real mentor. Whatever, you have laid down the guidelines for alcohol liver disease, you have mentored 86 students. I think phenomenal. Whatever you, a person, can think of or aim to achieve in life, you have done that. And I think Indian community, and I hope I'll take a comment from Professor Sareen also, is proud of you. Congratulations.
Thank you. I'm really honored to be not only part of NAMS, which is run so nicely, but also being on the same platform, as I said, not only people from India, but from America, and Dr. Sanyal, and Dr. Chalasani, Dr. Narula, and Dr. Kautilil. So really proud of, and really a great moment for me.
Ashwani,
Yes.
nice to see you online, and thanks. And I enjoyed your presentation, and I would like to ask you that you should certainly contribute to NAMS, the National Academy, and maybe next year plan your trip when the next meeting will occur, which will be in Chandigarh by Dr. Behra. So he will be writing to you so that you can join there in Chandigarh. Thank you, Ashwani. Great.
I will, sir. Thank you very much. It'll be proud moment again and an honor. I'll be more than happy to do whatever you ask me to do. Thank you.
Thank you very much. Our next, Dr. Arun Danial is the director
Yeah.
at Sinal Institute of Liver Diseases and Metabolic Health. And
Ashwini, can you unshare?
I invite Dr. Sanyal for his.
Thank you. Can you see my slides?
No, yeah, the slides are
Okay,
visible now.
thank you. So, dear colleagues, respected members of the Academy, and friends, it is a great honor for me to be considered to be a member of this August Academy. And I will, over the next 5 or 10 minutes, go through, uh, um, hold on, I'm having a little technical difficulty over here. Uh, yeah, go through my journey with you. So, first, a brief introduction. So, my disclosure is that I'm an unashamed liver lover. So, that's my disclosure. I graduated from Maulana Azad Medical College in New Delhi and then did my MD in medicine at All India Institute, following which I moved to the US and had to repeat my medicine and eventually did my GI hepatology training in Virginia, where I remain to this day. I'm currently the director of the Stravitz Sanyal Institute for Liver Disease and Metabolic Health at Virginia Commonwealth University. On this slide, I highlight a few of my academic milestones. I'm pleased to inform you that my H index now stands at 171, and I was very fortunate this year in being recognized by the Stanford University as the most impactful investigator worldwide in gastroenterology and hepatology, with over 20,000 citations last year alone. I've been funded by the National Institutes of Health since 1995 and have had 5 NIH grants continuously for the last 20 plus years. I was secretary and then president of the American Association of the Study of Liver Disease in 2010, becoming the first Indian to achieve this position, and was a founding member of the American Board of Internal Medicine Transplant Hepatology uh, Committee. So, reflecting on the journey so far, my career path really has been guided by my patients. And this is what I teach all my trainees. I have had the good fortune of having 200 plus trainees from all over the world. And what I have learned and what I have taught my trainees is that to listen to your patient. Each patient is a walking, living textbook of medicine telling you what's going on in their bodies. And from them, you learn what are the issues that you need to tackle, what's important for them. And that has always been my guiding light. Early in my career, starting as a faculty member in the 1990 timeframe, we performed the first studies of transjugular intrahepatic photosystemic shunts and defined the way they are used. And to this day, that remains the basis for how this procedure is used around the world. We've also identified the common problem of tip stenosis, which led to the development of coated stents, which are now used all over the world. This was followed by continued studies in the area of end stage liver disease, where I helped establish rifaximin therapy for hepatic encephalopathy and led the pivotal trial for that, along with Tony Bass, and then subsequently have led pivotal trials for terlipressin for hepatorenal syndrome. In 2008, while I was a member of the governing board of the American Association for Liver Disease, I worked with Bruce Bacon, who was the president at the time, to help establish hepatology as an independent science and was appointed a founding member for advanced hepatology in the American Board of Internal Medicine. Subsequently, in 2010, while I was president of AASLD, I led the US national effort to establish access to hepatitis C care through the Trust for America's Health and had it written into law, thus creating the first national policy for hepatitis C eradication and setting the bar for the World Health Assembly and the WHO to subsequently followed with global eradication targets for hepatitis C. In 2015, realizing the need for continued dialogue between academics and regulatory agencies, I founded the Liver Forum, which brings the European Medicines Agency, the US Federal FDA, and academics and industry partners together to work on issues related to drug development. And this has become the principal path for liver related drug development in North America and the EU. And of course, along the way, have tried to remember my roots and why I joined this business in the first place, and that is to improve the life of patients. And in 2020, when COVID broke out, I was one of the first on the East Coast to start trials in COVID and led the COVID response in Virginia and helped bring the first COVID drug, remdesivir, to market. But my true passion really lies in the area of metabolic medicine. So, on the left, you see results from one of my studies published in 2001. And in this study, we first identified the linkage between insulin resistance and a condition whose etiology was not previously known and used to be called non alcoholic fatty liver disease. And what you see is a progressive decrease in the glucose infusion rate during an insulin clamp from controls to steatosis to steatohepatitis, confirming the relationship of this condition to insulin resistance. Now, as shown on the right, this has led to a journey through metabolic health and disease, which started from insulin resistance to developing mechanistic insights, where we were also the first to demonstrate oxidative stress, nearly first almost simultaneous publications with Steve Caldwell on mitochondrial abnormalities in NASH, first to do omic-based studies, including lipidomics, proteomics, microRNA, and next year we will demonstrate microRNAs isotypes and develop isotype-based RNA therapeutics for NASH, role of cellular mechanisms such as unfolded protein response, and have established the mechanisms by which PNPLA3 gene mutation actually leads to disease progression, and also was one of the first to demonstrate the changes in cholesterol and lipoprotein metabolism linking the liver disease to cardiovascular disease. I was asked to chair the NIH NASH Clinical Research Network, and through that body and through our own work, we have described the clinical course of the disease and established the first prospective large-scale longitudinal data to demonstrate the natural course of the disease. I lead the Foundation NIH, or the federal US activity to develop biomarkers. And we developed FIB4 in our unit and are currently leading federal efforts for biomarker qualification in this area. The insulin resistance story also linked us to therapeutics, where I have led the first trials for FGF21, PPARs, FXR, vitamin E, and recently led the pivotal trial for semaglutide, which we reported last week at the American Liver Meeting, demonstrating the ability of semaglutide to reverse both steatohepatitis and fibrosis, a game-changing event, I think, in the metabolic space. And through these studies, connecting the liver disease to cardiovascular disease, diabetes, chronic kidney disease, and now Alzheimer's disease. So my current efforts are focused now on integration of liver care into pathways for an overall holistic integrated care for the full spectrum of non-communicable diseases globally. At my day job, I also serve as chair of the Division of Gastroenterology and am the director of the Stravitz Sanyal Institute. So our focus at this institute is to reimagine the future of academic medicine. Over the last 20 years, academic medicine has faced tremendous stresses from limited funding and increasing demand for clinical service, limiting the time to do research, teach, and foster the growth of new researchers. A major element of what we do is to really create a platform for learning to launch and foster the career of future generation of providers and scientists by giving them both immersive training as well as through mentorship. Our focus is translation, which means we focus on discovery science that can move to preclinical models and then into human studies, and then focus on regulatory science, which is needed to bring those projects all the way to market, and then focus on access and health policy. And this is done not through the classical academic paradigm of federally funded studies, but with a very active program with public private partnerships. We are creating an imaging center where we are focused on imaging function, not structure. So imagine we can now image physiology. We have access to cohorts. We're focused on analytics innovation. We're building a worldwide biotech support engine around our institute to bring new drugs and diagnostics to improve the care of patients with the single minded goal of solving the big problems of tomorrow, today. And of course, all of this creates an environment that fosters excitement and the desire for next generation of people to engage in science. So, what I hope to accomplish in the future is to revolutionize liver care and metabolic health care to improve overall health and save lives. What I show over here is my partner, Dr. Richard Stravitz, with whom we believe we can dare to dare. D for dreaming the impossible dream. A, the ability to make dreams a reality, to be resilient while never forgetting our empathy for patients and those who are suffering and for whom we get up every morning. In India, we have established collaborations with All India Institute, the ILBS, and the West Bengal Liver Institute. And I'm particularly proud of the SHARP initiative, where we bring in young, upcoming investigators with whom I have established a longitudinal, ongoing relationship to mentor them and to help them become independent. And I continue to look forward to working with collaborators and partners in India to build the next generation of physician scientists and prepare them to take on the health challenges, both of today and tomorrow. So, again, with this, I want to express my deepest gratitude to the Academy for considering me for membership. Thank you so much for listening to me.
Thank you very much, Sir Dr. Sanyal. It's a great honor to have you associated with our NEMS, and you really deserve a lot of appreciation and congratulations for your achievements, and you have achieved and contributed very richly as a landmark in the field of your liver disease and metabolic diseases, and we really appreciate and enjoyed your talk. Thank you very much.
Thank you.
Mr. Serene, sir, any comment?
It's very heartening to see how young Arun remains. Every time I listen to him, you can see his vision is increasing and enlightening the world. We're very proud of you, Arun, and the Academy feels very privileged. And I do hope that sometimes when you come to India, you also address the NAMS fraternity and also contribute to mentoring more people. Thank you for being
I look
part.
forward to it.
Thank you for being part of the Academy now onwards. Welcome.
Thank you so much. Thank you so much, Shiv.
Thank you so much. I think we change gears and now shift to our third talk, that is by Professor Jagat Narula, who is the Executive Vice President and Chief Academic Officer at the University of Texas, Houston. He is also the last Gold Distinguished University Chair for Coronary Pathophysiology at John P. McGovern Med School at Houston. Over to Professor Jagat Narula.
Thank you so kindly. And I'm truly, truly honored to be joining as the fellow of the Academy. And I'm grateful for the honor. I'd like to start with two disclosures here. One, that I have followed the trajectory of Dr. Shiv Sareen, who was 5 years senior to me in medical school. And I've literally followed him like my idol, first to All India Institute, but then later left and joined the Harvard Medical School and Mass General Hospital. The disclosure includes that he has been telling me for at least 5 or 6 years now that Jagat, it is all in the liver, and you need to start collaborating with the liver people, which I have been somehow or the other avoiding for such a long time, fully realizing now that it has become almost impossible to avoid the liver because probably it all starts there, which Dr. Sareen has been telling me all along. And the second disclosure here, thank you, Dr. Sanyal, making my job a lot easier, and which is what I will carry from here on. So I'm trying to bring this personalized medicine or precision medicine over to the population health here in the next 10 to 15 minutes. Then I have no financial disclosures here. So I would say plaque, patient, or population, and can we eliminate coronary disease in our lifetime? And that is one pledge that I move on to become and take over the president of the World Heart Federation starting next year for 2 years. So it is always easier when we start to discuss some of the celebrities or some of the major people who have had major adverse cardiovascular events. So I'll start with Bill Clinton here. As you can remember, in 1992, when he was taking over as the president of the United States of America, at that time, whenever you join as the president, a physical examination is done so as to establish your physical vitality. And as you can see here, that he has done exceptionally well overall. He was put onto the treadmill where he went to Bruce stage 5, achieved 91% of maximum targeted heart rate. But he was not tired. He did not have symptoms. Somehow or the other, doctors stopped the test at 91%, which is much more than what we normally require. There were no electrocardiographic changes, no myocardial perfusion abnormalities, and obviously, with the certificate of immortality, he started his presidency. Whenever we talk of coronary disease, we always talk of chest pains. We always talk of the stress test. If the stress test is normal, we think that you are doing very well. 1999, his total cholesterol is less than 200. LDL is about 130, normal for those days. And 2001, he's relinquishing his office. And as you can see here, cholesterol and LDL both have jumped about 40 points. All the information is on yahoo.com, and there is no HIPAA violation or the confidentiality breach. And then after that, there is nothing in the web. But in 2004, It is when he developed unstable angina that he required an emergency quadruple bypass surgery. So, a person whom we never believed had coronary artery disease suddenly develops an acute coronary event and requires a cardiovascular intervention. Another example, Tim Russert, a celebrated NBC journalist who had his treadmill test in April of 2008. We knew that he had coronary artery calcium in his LADs, but was receiving some level of statins. He was diabetic, some level of diabetic medicines and all, and treadmill tests, which were absolutely normal. 6 weeks later, when he was holding an interview in the NBC studios, he died suddenly during the interview. In him, we knew that he has a coronary artery disease. Both of them had normal stress tests, and they both had significant major events without having a with having a normal stress test. And you can find the same examples in India also, whether it is Saif Ali Khan or it could be Siddharth Shukla or KK or Sunil Grover or multiple other people who have had the interventions at very young age of 30s, 40s, or 50 years of age. Why is it that they don't have a chest pain? Why is it that they have a normal stress test and still they have significant cardiovascular events? And the answer lies in the plaque pathology. When you look at the plaque pathology, the plaques which lead to an acute event or which result in sudden death or myocardial infarction, these are the plaques which have huge or large necrotic cores. You will see that it is full of cholesterol crystals here. They are covered by a very thin fibrous cap, and the fibrous cap, where it is thinnest, it is amenable to the hemodynamic stress. And if it ruptures, it exposes the thrombogenic core to the lumen, thrombosis is formed, and there is an acute myocardial infarction or sudden death in these subjects. Now, let's presume that we have the same pathology as you can see here, that is the large necrotic core, very thin fibrous cap, but the cap is still not ruptured. It is still intact. It is very thin, attenuated, it is inflamed, but it has not ruptured. We call these plaques as high risk plaques or the plaques which are vulnerable to rupture. You'll find two other similar plaques here. The again large necrotic core, thin fibrous cap, large necrotic core, thin fibrous cap. The difference in these three, although the pathologic signatures are same, the difference in three is that here the lumen is not affected, here the lumen is only modestly affected, and in this case the lumen is critically affected, and all three are amenable to having an acute coronary event. Why is it that you would have such large or huge necrotic cores full of cholesterol crystals, full of thrombogenic necrotic core, but the plaque does not rupture, but the plaque has not encroached upon the lumen? The reason is something what we call as outward remodeling or the expansive remodeling or something what we call as a Glegovian phenomenon or Glegovian remodeling. That is, first, when the lipid collects, the plaque expands outwards until about 60% of the total vessel area is occupied by the plaque. It is only after that that the plaque starts to grow inwards. So, if this patient would never have a chest pain, this patient would not have a positive stress test, but he's as amenable to the acute coronary event as the patient shown in the right upper corner. Compare it to the stable plaques, that is the plaques which have got huge or big fibrous cap or thick fibrous cap, which is not going anywhere. And if it leads to the luminal occlusion, quite like here, it will cause the chest pain, the so-called common garden variety, which we think of for the coronary artery disease. However, there are two-thirds of the people in whom the first presentation of the disease could be a major adverse coronary event, whether it is sudden death, it is myocardial infarction, or it is unstable angina. So, how do we find these Waldos? How do we identify those people who are likely to have an event? And how are we going to find those people who die of the preventable events and when And then how do I find out those people who are likely to live without events? And that is something which we started to do back in 2003 when we started to do the CT angiography. Before that, I used to indulge more and more in the molecular imaging. We identified multiple techniques, but wanted to get to something which could be immediately clinically applicable. And as you can see here in the CT angiography, the patient who has had an acute event, he has got a significantly positive remodeling, that there is an expansion of the plaque outwards, and you can see a huge necrotic core, which can be seen as the low density here or low attenuation plaque. So we call these plaques as two feature positive plaques. That is, they are positively remodeled and they have low density necrotic cores in there. And those which are stable plaques do not have these features. Now, neither all of these people who have such plaques are going to have an event, nor these people who do not have those features are going to be spared of these events. And why is that? And that is because there is a plaque progression. So normally for up to about 2 years time, if I've gotten a negative scan, I basically might see that the people have a benign outcome. But then over a period of time, some of these plaques may grow and progress. And similarly, the high risk plaques also, they may progress over a period of time and may result in an event. We have seen, this is a study of 3,000 people followed for 10 years, and you will see that only those plaques undergo rupture which have progressed over a period of time. So these are where the serial CT images were available. If there is a high risk plaque, but it has not grown over a period of time, it is not going anywhere. On the other hand, even if it was a non-high risk plaque, but it has grown over a period of time, it is going to have an event. So basically, there is a tenfold higher likelihood of having an event if there is a high risk plaque. But at a given time, there are 90% of the plaques are non-high risk plaques. So at the end of 10 years, 50% of the events occur from the high risk plaques and 50% of the events occur from non-high risk plaques, bringing us to square one. And we needed to identify as to how exactly we will identify these Waldos who are likely to have an event. And we started to look at now, based on the leveraging the AI for the personalized treatment strategies. We identified multiple CT angiography features, both the plaque characteristics as well as the hemodynamic characteristics,
Narula,
and
you have
identified four
Dr.
important features.
Dr. Narula, you
More
have to be
the
little
more
brief.
severe the stenosis, more is
Hello,
the likelihood of having
am
an
I
event.
audible, Dr.
More
Narula?
the bigger the low attenuation plaques, bigger the positive remodeling, more is the likelihood of an event. More the plaque burden, you'll see that greater is the likelihood of an event. And if there is a hemodynamic uh, decrease.
Hello, Dr. Narula, you have to be brief. I
Okay,
think
sure.
we are running
So,
short of time.
yeah,
That's a
so
very
I'm coming to an end of the talk. As you can see here, that these are the risk factors, that there is high cholesterol, smoking, hypertension, diabetes, obesity, stress, lack of consumption of vegetables and fruits, alcohol, and the lack of physical activity. Greater the cholesterol, greater is the likelihood of having an event, whichever country or whichever continent you go to. And not only that, we have demonstrated that in hundreds of mummies that we have scanned, that even the mummies, based on their behavioral patterns and dietary intakes, they had an evidence of the coronary calcium. And even if we go to the not to the Egypt, but to the other areas where we have seen the commoners, we found that they also, up to about 24% of them, had an evidence of calcium. They lived in the huts like this and cooked inside, quite similar to what you see in the indoor pollution in the low and middle income countries. And then we ended up with a hunter gatherer population which walks the whole day, is eats one time a day, and they consume the pigs, jaguars, and monkeys. And as you can see here, that this is the my most favorite couple, 99 years old woman with her 85 years old husband, and they live in the open huts. There is no pollution, and when their LDLs are less than 70, blood pressure is less than 150, fasting blood sugar has been less than 80, BMI of less than 24. They walk about 15 to 17,000 steps. There is no pollution, and they have no coronary artery calcium as compared to all other the populations that we have done, even in their 80s. And as we have seen, that we need to bring our cholesterols down to about 50 if we have to have a primary prevention, and even less than 30 if we need to have the secondary prevention. And that is what all the animals of the world have: less than 100 cholesterol. Their LDLs are lower than their HDLs. That is what happens when we are born. We are born with 25 milligrams of LDL, which reaches 130 to 150. So the question to be asked is that if we started something like what Dr. Sanyal was telling us, that they are going with the mRNA therapeutics, which are now available for the PCSK9, if we started to have one shot a year, we will be able to bring our cholesterols down to LDL cholesterol down to 50, and we should be able to live to 100 without having a heart attack. So that was the population, and I would stop here. And I thank you once again for this opportunity and the honor of joining the Academy as your international fellow. Thank
Thank
you.
you very much, Professor Narula. It was a mesmerizing talk. The message you gave, lower the LDL, better it is. And as the view say now, better to have less than 50. And you also gave a beautiful idea about the plaques. Some are remodeling outside, not encroaching the lumen. Others are going towards the lumen. And the duct chalice, the cholesterol should be low. I think once again, I think Professor Serene is giving a feast to all of us. Wonderful researchers. I congratulate you, Professor Narula, for wonderful talk and the huge achievements you have got. Again, it's an honor for National Academy to honor you with the fellowship. And I think since you mentioned in between that one of the mentors was Professor Sareen, so I'll request him to give a final comment before we move to the next talk.
Before
Please,
that,
please.
hi Jagat, this is Shiv Gautam here.
Hello, Dr. Gautam. How are you?
All well. Nice to see you here. And we welcome you to the National Academy of Medical Sciences.
Thank you.
What was very, very nice from your talk was to look at the younger population of 30s and 40s and giving us an insight about it, how not to have plaques. And I also would like to congratulate you for taking over the president of the World Heart Association. And such a pleasure to recall the old days with you. Okay.
Thank you.
Thank you, Jagat, and it is a pleasure to see you. And we are very fortunate that you are inclined to work and join the National Academy. Also, that you have done so much with humility and grace. You have not only brought honor to the country, but all Indians living anywhere. Salutations and hope to have more productive work from you. And welcome to the National Academy. Welcome.
I'm honored. Thank you.
Thank you very much. Now we proceed to the next speaker. And I'm really honored to call Dr. Naga P. Chalasani, who is from the University of Indiana School of Medicine and Vice President of the Academy Affairs of the Indiana University Health. So, Dr. Chalasani, please.
I think Professor Chalasani had to leave. Now, may I request Dr. Shama Sundaran, Cottville, a Director, Institute of Virology at the University of Maryland, to give his presentation today. I'm sorry we didn't announce your name initially because Dr. Chalasani was there. May I request Dr. Shabasundaram Kotilil to go ahead and give his presentation.
Thank you. Can you see my slides?
Oh, yeah, we can see that. Make it full screen.
Thank you. First of all, let me thank the Academy and the eminent members for induction into as a nominee of membership of the National Academy of Medicine. It's a great honor to be recognized with my fellow speakers who have accomplished so much and has been role models for me throughout my life. Let me briefly talk about my career. I'm an infectious disease, slightly different than most of the speakers here. I started my journey from Kerala. I was born there. I did my medical school in Medical College Trichy. And then I did my PhD in immunology. And then I did internal medicine residency at Brown University and then infectious disease fellowship at NIH. And so I stayed at NIH, and most of my work was in virology, HIV, hepatitis, and different types of hepatitis viruses. My wife is also an infectious disease consultant, and my only daughter is a senior at Yale University. So before I go talk about it, I'm the director of the Institute of Human Virology. Institute of Human Virology is the first and the foremost virology institute established in the world. Because there was no virology institute, there was not need for virology institutes in the past. We have a great global impact located in Baltimore. We have impact on education, research, and clinical research across the globe. We have treated over 9 million people with HIV, particularly in Africa and many parts of Asia. Received over $2 billion of CDC funding to conduct and educate HIV and hepatitis program worldwide. Obtained over 100 patents, about $400 million of NIH funding, and over $100 million of Gates Foundation funding. We developed our own HIV vaccine, which is on our phase 3 studies. We have developed several monoclonal antibodies for treatment for many viral infections. And the big challenge for us is that developing human challenge model for studying viral infection, which is a big breakthrough for bringing in new therapeutics to the field. I just want to talk a little bit about it at the Institute and then move on. Just we have screened over 30 million people in Africa for HIV testing. 9 million people have been put on treatment. They still continue. A large amount of funding to conduct this particular research. Capacity building in various parts of our institute has branches in at least 4 countries in Africa. We have extensive collaboration. I've been very fortunate to collaborate with people in your audience, especially have been mentored by people like Dr. Serene. And when I was crossing over from infectious disease to the field of hepatology, and I have appreciated his friendship and guidance for many time. I'm giving back to the country. I do a lot of work in India. I'm continuing my work in LBS. I've been worked with in ILDS in Calcutta, and also fortunate to lobby and get money and funding for a research institute in Sonarpur called John C. Martin Liver Research Institute that's going to be inaugurated in a couple of weeks in Sonarpur. I'm also pioneered Kerala government to start the Institute of Advanced Virology for the Nipah epidemic to address that. And that's another institute in Trivandrum that we continue to work and build up in developing virology expertise. Our goal is to treat HIV because most of the effort has been based on HIV. And we have worked a lot in maintaining what you call as 95, 95, 95. That means 95% of the people are diagnosed. 95% of those people diagnosed are treated, and 95% of those people treated are suppressed for HIV viral load. And we have accomplished that in our own effort in multiple different countries in Africa. And that's very big accomplishment, required a lot of people to do a big global expertise. My own expertise has been on hepatitis part. So we have done several pivotal works in hepatitis in the last decade. I developed the first study to do a treatment of interferon-free regimen that led to the approval of sofosbuvir, demonstration of DAAs, different combinations and shorter duration, as long as 4 weeks of duration. You can actually treat and cure hepatitis C. Demonstrates that you can shift the model, and anyone can actually, nurses and other people can actually treat hepatitis C successfully. New models of care that has been adopted by WHO in treating patients in different settings, like substance use setting, incarcerated setting, as well as the cheaper short duration treatment. However, the hepatitis C and hepatitis B are really prevalent diseases in the. I want to finish off my presentation with a little bit of humility. Even though we actually have done a lot of work, there is still a lot more work to be done. 1% of the people are infected with hepatitis C. 300 million people have chronic hepatitis B. They are the major causes of hepatocellular carcinoma at this moment. Both of them can be treated or cured. Hepatitis B can be cured by treating for 8 to 12 weeks. Hepatitis B can be prevented by vaccination and also suppressed by antiviral. And if you do that, you have the risk of developing hepatocellular carcinoma is significantly reduced. However, and what we have seen is that from an infectious disease perspective, the major killers are HIV, tuberculosis, and malaria. Those incidents, animal mortality worldwide has gone down. However, the mortality due to hepatitis B and hepatitis C is actually going up, even though we have really good therapeutics available. And this is what I'm telling about. It is a really humbling experience for us. We have done a lot of work in developing therapeutics, but we actually haven't failed in implementation, diagnosing of people. If you look at the left side of the global statistics, about 300 million people have hepatitis B. Only 10% is diagnosed. Only 1.6% of the people have received treatment. 775,000 people develop new hepatocellular carcinoma each year. About 1 million people die. And every 30 seconds, one person dies of hepatitis B. In the way we look at hepatitis C, about 66 million people are infected. 20% are only diagnosed. 3% of the people actually receive treated. And it's also responsible for multiple deaths and one death in every 1.5 minutes. So we have a long way to go. And a lot of these things comply from our ability to translate what we have accomplished in the lab, as well as into the clinic and into the field. And there are several efforts I've done in India. The efforts and Dr. Deeman's effort in Punjab is quite remarkable and very, 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 very well accomplished. But we have to continue this process of emphasizing vaccination and spreading the message that a treatable disease like hepatitis B and hepatitis C can be controlled and led to elimination of the problem. This is what I think we have done a lot of work, but still a lot more to do if you really want to have an impact in the public health setting. So I will stop at that time, and we're going over time. I'm really, really again thankful for the Academy, for the membership, and all the members. Many of these people in the field I have been associated with or mentored with me, and my many appreciations and pranam.
Thank you very much, Professor Shyam Sundaram, and for giving a total picture of the world scenario about all the viral diseases, and with special mention, special emphasis on liver-related diseases. I think that has been very informative, and I congratulate you and the National Academy to honor such a great person like you. And I'll request Dr. Sareed to say a word.
Yeah, Dr. Shyam, it was nice to see you, and I've known you for ages, and I see how you have transformed the whole field and your dedication. Also, the immense amount of immunology background that you bring, I would think it will be very helpful for the academy. We have very few who have such in-depth basic science knowledge like you in immunology, especially of HIV, hepatitis B, and hepatitis C. I do hope next time when you come, you would be able to contribute to the academy, take more fellows, and all these steps you have taken till now, whether it is in ILBS or in Calcutta or in Kerala, have been really richly rewarded. And my best wishes, and hope to have you more active in the National Academy in India. Welcome to the
Thank you.
academy.
Thank you, Doctor.
Do we have the fifth speaker?
No, I don't think so, sir, because his flight was there, so I think he left. Actually.
If none, I think we will conclude this session, and all of you will agree that it has been one of the finest sessions. I mean, I congratulate Professor Sareen for bestowing the honor on such great personalities, I think, who have all done proud to India in their respective fields. And whatever they have spoken today has been very, very informative. And I think everybody enjoyed that. We stop here, and I request
It was really mind-boggling lectures, and we were really, we enjoyed it, and it was very informative. And the total credit goes to Dr. Professor Sareen, who has, imbibed such a great personality from all over the world. And with these remarks, I conclude this very much.
Thank you for the insightful thoughts, sir. But I request the chairperson to be on the dais because we will be continuing with the next session. And please be seated, sir. And I also invite GD Puri, sir, as a chairperson. Sir. The next session is in the virtual mode, and it will be on reinventing healthcare through disruptive, inclusive innovation.
Good morning. This important session is being shown the being reinventing healthcare through disruptive, inclusive innovation, and the speaker is none other than famous Dr. Raghunath Anant Mashekar, who is a well-known chemical engineer, Indian chemical engineer, Padam Vibhushan body, and he has got scientific advisor to the government of India, and currently the think tank is governing the future policies of India. And we are lucky to have him speak on the topic of reinventing healthcare through disruptive, inclusive innovation. Sir, please.
Yeah, can I share the screen, if you allow me to share the screen? Or you have the presentation already with you, or?
Can we allow the sharing of screen? Do we have the presentation?
Yeah, I had seen the presentation, but
Please share
I would.
Are you not able to share the screen, sir?
No, you have to allow me, no?
Yeah, sharing is allowed, sir.
We have already allowed, sir.
Okay, I'll just 1 second. I don't see the sharing button here, unfortunately.
So on the bottom line, there will be a share option. The green button.
There's a green button. Please press the green button, sir.
Yeah.
At the bottom, sir.
Oh, yeah. Okay. That's fine. Just 1 second. Yeah, can you see it now?
Yeah. Make it full screen, please.
Yeah, I'll make it. Thank you. Thank you. Yeah, you can see it now, no? Okay?
Yes, sir. Please go ahead, sir.
Yeah, sorry to have lost some time. First of all, my very dear friend Shiv, I want to thank you. You know, I have great affection and admiration for you, and I joined this meeting half an hour earlier, at 9:30 itself and learned so much from these brilliant presentations. So thank you for this opportunity. Let me straight away dive into the subject matter. I'm using the word disruptive, inclusive innovation. And one must understand the meaning of inclusive innovation. So let me explain that. What you see here is inclusive innovation. Because if you see these two ladies, they have the access equality despite income inequality to a mobile phone, something that was inconceivable, let's say, 20 years ago. Now, there is this access which can be given to education, to health, to several services, and it doesn't matter whether you're poor or rich. And that looks almost impossible. But impossible becomes possible when you actually do it. Let us look at the issue of access to education and how that access equality, despite income inequality, can create wonders. So this is the proof of power of access equality despite income inequality as an example. This is Ratan Tata receiving the Padma Bhushan, and on the same day, I also received Padma Bhushan at the hands of K.R. Narayanan. So how does it prove the power of access equality despite income inequality? The President K.R. Narayanan was born in a very poor family, walked kilometers to his school, and his parents were so poor they could not give him even tuition fees, so he would stand outside the class and take notes. My condition was not very different. I was born in a very poor family, walked barefoot until I was 12, studied under street lights. And both of us had a warm moment in our life. K.R. Narayanan got a Tata scholarship. That's how he could study. I got Tata scholarship. That's how I could study. And you can see that Ratan Tata and I, a Tata scholar, received Padma Bhushan at the hands of the then president, K.R. Narayanan, another Tata scholar. If we did not have access to education, this would not have been possible. And I'm very proudly sharing what happened yesterday. I was in Delhi and I received my 50th honorary doctorate, surpassing the record of Dr. Kalam, revered Dr. Kalam, of 48 honorary doctorates. This miracle would not have happened if this magic of inclusive innovation, access equality, despite income inequality, was not possible. Access to education was most important. I want to make this general point and then move on to healthcare. As was mentioned, I'm a chemical engineer. I'm not a medical doctor, but I'm a great admirer of medicine, medical doctors, and the miracles you have been able to do. This was a corporate story in civil society on trailblazers with inclusive innovation on how we can reinvent healthcare. What India needs is affordable excellence paradigm to solve healthcare challenges. Affordable because low cost to be enjoyed by people across all income segments, not only by India at 75, but also Bharat at 75. Accessible because in remotest areas of the country with no dependence on proximity to cities, it should be accessible. High quality, healthcare of excellent quality and performance using highest technology. And finally, products and services that are user friendly, irrespective of individual skill and levels. One, two, three, four, they are extremely important. And I will just focus on the aspect of this access equality despite income equality. I created in my mother's name an Anjani Mashelkar Inclusive Innovation Award and later on a foundation. There were two conditions that I put, that you have to create next practice. Don't follow the best practice. I'm not a great believer in best practice because when you say I'm following best practice, you are a follower. You have to be a leader. And for that, you have to create next practice. Also, making high technology work for the poor is absolutely the key. And we have been giving the thoughts and promoting this for almost 40 years. You can see some of the products that have come out and which have been awarded by Anjali Mashelkar Foundation. I am very proud that many of them are in 10 countries, 12 countries, 20 countries, one even in 50 countries, as I will sort of show you. These are the proud award winners. I wish I had time because I've been given 30 minutes. I have to finish within that. There are 16 award winners. Each one of them meets that criteria of next practice and making high technology work for the poor. Those of you who will be interested in looking at details of each of the disruptive inclusive innovation, they're fully available in this mashilkarfoundation.org, our foundation website, as well as on the Twitter. And you can have a look at it. But what I'm going to do, because of the limited time, is covering only cases of disruption of inclusive innovation using AI, artificial intelligence, because I'm a great believer in the power of artificial intelligence in making a big change and what difference it can make, making that high technology work for the poor. Uh, the first example is Shwasa, which is a respiratory health screening. It is actually a software as a medical device solution which offers early screening of respiratory problems and uses AI-powered analysis of cough sounds to detect and monitor respiratory health. The interesting part is that it is inexpensive. Per assessment, just 1 rupee, if you can believe it. It is, of course, scalable because all that it requires is a mobile phone, and there are 500 million mobile phones in India. So it is extremely scalable. It is unbound, no consumables. It is accessible, available everywhere, easy to operate. And in real time, 15 seconds, you can do an assessment. Now, if you go back to best practice versus next practice, best practice, yes, all of you know, is spirometry. And this is the next practice, just a mobile phone, which is trained by AI for its audiometry, and it diagnoses respiratory problems using biomarkers. And just look at the cost. Spirometer will be 1.5 lakh. Here you already have a smartphone. Assessment will be 1,000 rupees. No, here it is just 1 rupee. Time of results 90 minutes or 60 to 90 minutes. This is almost instant. And if you see the way Shwasa works, actually, look at the cough sounds, St. George's respiratory questionnaire, Shwasa is used, and the general lung health with rich data, and the disease prediction is done. So the role of AI here is machine learning algorithms are used, uses lakhs of data points to detect respiratory conditions from cough biomarkers. And this is the kind of output you get. So both instantaneous as well as longitudinal monitoring is available, and doctors can review reports remotely of patients from any corner of the world. All that you have to do is to cuff into a smartphone. And I'm very proud to see this because all these are not jugards. They are based on very high science. Look at these. There are 2 papers in Nature based on the deep science, of course, also in other journals and so on and so forth. So when I talk about affordable excellence, that excellence has to be in terms of high science, high technology. And of course, it has got all important certifications, including FDA and so on and so forth. And you look at this impact, the government partners, of course, Central TB Division. There are private partners, the Apollo Hospital and Dr. Reddy, CMC Wilkor, and so on. What is very important, because I talked about making high technology work for the poor. For example, this laborer doesn't have to go off and get a spirometry test done, which he can't afford. From where he is, actually, you can do that, and that doesn't compromise on his daily wages. And he, of course, the team got the Anjani Mashikar Award just 2 years ago in 2022. SASIT Technologies. Look at this DOSI, for example, patient safety and remote monitoring. This is a contact-free AI-backed remote monitoring and early warning system that provides customizable and timely alerts to healthcare staff and patients' family. And this is world's first non-contact blood pressure measuring solution. What it does is simple. A sensor sheet designed on the concept of ballistic cardiography is inserted under the mattress of the patient, which captures all micro and macro vibrations. And the role of AI here is that it has an advanced AI algorithm which processes this huge data and offers an early warning signs for abnormal vitals. It is, of course, FDA certified. It has appeared in 16 peer-reviewed journals, international patents, as you can quite clearly see. And the impact, once again, you can see the best practice and the next practice. Uh, our current best practice also suffers from undersupply of nurses, infrastructure leading to unavailability of critical care and human negligence, whereas this is non-invasive, continuous, real-time monitoring and risk allocating system. Equipment costs 2 lakh versus 25 times cheaper, 8,000. Assessment cost, you can see the huge difference, and the monitoring time, because now here you do the monitoring in the periodic window, and here there are instant alerts and 80% reduction in nursing time. And this is the way, for example, this is an example where there was sudden surge in one of the vital signs at 2 a.m. And there was a signal that was notified to night shift manager, and the doctor, when they visited, they found the patient in extreme pain. So there have been 210 life-saving alerts per 100 beds, and 91% patients undergoing health deterioration are alerted 8+ hours in advance. So this is the impact at scale. Remember, these are recent awards, 3 years ago, 4 years ago. And this is the kind of impact. There are 14,000 dosy beds, 200 plus hospitals, 350,000 patients have been monitored, and 14,000 timely interventions, and so many nursing hours were saved. And Mudit and Gaurav Parchani got the award during the COVID time, by the way, because I had created a special award which helps in COVID time because people were dying in ambulances. ICUs were full, and this was kind of a stand-up ICU kind of a method. Then there is this last year's awardee, again AI-based, IHRA, Intelligent Health Risk Assessment. This is a pre-diagnostic method for the early detection of type 2 diabetes, and it makes risk prediction of diabetes in early subclinical stages possible, long before the intended medical conditions can be clinically diagnosed with the current methods like blood tests or blood pressure and so on. And this is the way it works, as a matter of fact. There is a 1 minute video on FDA cleared third party thermal camera. The thermal video processing takes place, the biosignals are assessed, and the reports are created. So IHRA algorithms principles are based on analysis of this versatile nature of the blood flow through emitted infrared radiation and modeling its variability under the influence of metabolic conditions like diabetes, like hypertension, like dyslipidemia, and so on. And it is FDA cleared, it is CDSCO cleared, and already 3 patents have been actually granted. And this is the next solution by Arca Research, which are actually, it's a handheld, ultra-portable multi-parameter device that allows convenient, cost-effective, and accurate way of monitoring metabolic health. It uses photoplasmography. And it's amazing, but Arca's proprietary software can measure 20 plus parameters related to metabolic health. And you can see now the best practice. Here, you have to take the blood test, no early detection test, diagnosis done only when the conditions reach a clinical recognizable threshold. But here, it is non-invasive, ultra-affordable, real-time early screening. And you can see the difference in the cost, 1,200 to 1,500 versus 10 to 100 rupees. And it takes so many days to complete the reports, whereas you can get instant results. And I'm very happy to see it penetrating with the government partners, with corporate clients. For example, TCS, they do the risk assessment, and now there is only fraction of their thousands of employees who are sent for the diagnosis. And I'm very happy to see the big mark it is making. And this is this young girl, Gayatri Choda, who has done us proud, who got the award. There is this Save Mom, by the way, is a IoT-based maternal care platform that provides continuous monitoring and AI-based early risk prediction. So what it does is that there is a variable and that uses PPG sensors for continuous data monitoring of steps, calories, sleep pattern, etc. And there is a particular device that is given to the health worker that periodically records vitals of the pregnant woman, including blood pressure, blood glucose, etc. Uses PPG, infrared thermometry, and ECG techniques to measure these parameters. And the platform is a AI-based decision support system for hospitals and doctors, and scores and monitors 35 data points of a mother. And AI is used by training it on data of thousands of mothers and predict risk in pregnancy in the first trimester. Now you can see the difference. This is the typical scenario here, and this is what you are looking at as a contrast. These are invasive, expensive ways of health monitoring only at the hospital or labs. But here, it is non-invasive and it is intelligent tracking and processing. You can see the difference in cost, 5,000 to 50,000 here, 1,000 for 1,000 days, 1 rupee per day, because it not only monitors the pregnant mother, but also the child. And results here, you have to spend few hours a day, and this is instant. Absolute, affordable excellence. I'm very happy to say that Harvard did Simam design thinking case study in Harvard Business School. It has already boarded 36 lakh women, 5,000 successful deliveries. 4 state governments have already partnered with it. And recently, Bangalore Municipal Corporation is monitoring 1 lakh pregnant women. Well, most importantly, this Deakin University, this A212 school in artificial intelligence is among the top 5, and they approached us. They want to sort of partner, and this is actually the risk prediction algorithm that they have developed. Actually, the accuracy of the algorithm is already improved by 10%, and the software will now better predict risk in pregnancy in the first trimester itself, as against later stages, and you can see the vast difference it can actually make. And Senthil got his Sevimom prize, by the way. And the last one, this is not artificial intelligence, but just want to show you our young people, what difference they are making. All 16 people that you saw, their age group is 30 plus minus 3-4 years, by the way. Okay, all of them. And this young man, for example, this is not AI based, but just as an illustration, he created this actual state. It's an advanced wound dressing known for stopping profuse blood flow instantly, minimum preparation time, and completely stops massive bleeding in just over 2 minutes, by the way. Okay, as against standard laws of 13 minutes. And this utilizes a very unique biomaterial. It has got FDA clearance, CE clearance, and there have been sort of publications. I want to proudly show you that early this year, this was a publication in Proceedings of National Academy of Science. There are hardly any papers, by the way, that come from India in this journal. And this one actually has been in partnership with Harvard, of course, an architecturally rational hemostat for rapid stopping of massive bleeding on anticoagulation therapy. And look at its impact, for example, its presence in 50 plus countries, 300 plus battalions in Indian army. And you can see its impact in terms of life saving in road accidents due to zero preparation time, widely in Indian Army and used in surgical trauma. And Leo Mauli, this young man, you can see, got this prize, Anjani Mashaka Prize. I like to end by talking about it's not an easy journey because they are disrupting whatever is being done. Because once you are non-invasive, there are so many who lose jobs. All right. And this disruption causes something of a shock to the conventional practitioners. So the first is lack of trust of medical ecosystem, despite US FDA approvals, by the way. Second, long scaling period. All stakeholders freshly ask for pilots. Third is ecosystem struggles with adaptation of any disruption, any change. It is very hard to accept. And VCs ask for burn rate. fat margins, shift focus for good take and impact. And finally, the government is a key stakeholder, but bound by long processes. In fact, Dozy, we had a major problem. I mean, in COVID, people were dying in ICUs, but the government hospitals will not take this for a simple reason that their processes will not allow them without tendering. And tendering will take 2-3 months, and by that time, lakhs of people would have died, so as to say. So finally, we had to innovate and get some high net worth individuals to donate Dozy. And that is how it started. Now, of course, it has kind of picked up. So these are the challenges. Our foundation is now just not giving awards, but it is going beyond. Of course, it does recognition. It has created funding mechanisms, with compassionate equity. Like just on 25 September, Keki Gada, at the age of 95, he actually created a foundation with 30 crore sort of first tranche, which will be replaceable, to help just these people. Because these people are going for values, not for valuation. These people are not going for billions of dollars. They are going for bringing smiles on the faces of a billion. And somebody is needed there. And venture capital becomes vulture capital. And therefore, we needed this adventure capital that is provided. Our foundation is trying to create government partnerships, outreach deployment programs, help them in research and technology development, and talent partnership. So, last slide, how can we all help, as a matter of fact? Do we have the talent? Yes, we have the talent. And you saw some remarkable breakthroughs which have gone to 10, 12, 20, 50 countries. Do we have the technology? Yes, you saw the demonstration of these remarkable technologies. Talent is there, technology is there. What we need is trust. Okay? And that is where a lot of challenge comes. I remember Navin Khanna, for example, he had developed dengue test which detect dengue within 15 minutes. He had to use the FDA certificate. He had everything going for him, but nobody will take it. I have not shown that, but this is a brilliant example of trust. Because we are sort of importing things from Australia, South Korea, and US. Then came pandemic, and we were exhausting all the kits. So what do? We went begging to these countries. Only South Africa, the South Korea said we'll give it in time. But as luck would have it, they boarded it on the wrong ship, and which went to Africa. We were short of kits, huge shortage of kits, and then they had to turn to Navin Khanna. Navin Khanna's market share was 0%. It became 75% today, 75 to 80%. But if the ship had come, it would have been still 0%. So we have to have trust in our young people. All these 16 are, as I said, 30 years plus minus, and they are doing such a remarkable job. They are not within the conventional medical research system. They are outside. They're all startups. But I want to very proudly present this talent and technology to you and beg for your support, because your helping hand will make them move faster, make them do better, and save many, many more lives. Thank you. Thank you very much indeed.
Thank you very much, Professor Mashelkar, for wonderful. And you taught us that to achieve the goal of health, you have to go to the masses and develop innovative, uh, cheaper versions. In Indian Army, we have been doing it. I remember when I was head of medical setup uh, around 15 years back of JNK and Siachen. That is the time we used to transmit our ECGs by the mobile phones. So we had given to all posts in Siachen all the urokinase that time, that if a person has developed heart attack, do it. I think whatever you have shown, SWASA, DOSI, IHAR, our metabolic profile, that is pretty useful. As you rightly mentioned, there's no dearth of talent. There is no dearth of innovation in Indian minds. It is you have to bring it in a qualitative way, in a trustworthy way, that people have got faith in. Sometimes people start feeling, "Arey bhai, ₹1 ka test hai, isme kya hoga?" I don't know whether it's a trustworthy or not. But
Sir,
That
you are
trust,
absolutely right. That is the problem.
yeah, so
That is the
that
problem.
trust you have to develop that whatever we are doing in small AI conductive innovation is truth, is real truth. And I think I think you can also bring out the ECG and ultrasound that people are bringing out. It is available in the Western world that if you can bring out on a mobile the ultrasound also, I think that would be even more useful. And but I must compliment you that wonderful. No wonder you have got 50 doctorates, that you have done huge work for the mankind.
Thank,
Any further?
thank you. Thank
Yeah. Congratulations, Dr. Mashelkar. I think it was a state of art lecture, and I think the topic also can be a little bit different. Progressive rethinking innovation.
Yeah.
This is probably also, instead of disruptive, probably it is more of a progressive rethinking innovation. And I feel that as a medical associations and bodies should validate all these new researches or new innovations, so that they can be useful day to day, and then it will be authenticated, and then it will be applicable, accepted by the court of law, etc., etc. Now, also with your very innovative topic, it opens up the chapter of same progressive rethinking innovation in the field of medicine, where we have been doing a lot of things and which requires rethinking. And this already we have been doing, and then we should be actively doing that, which will help us further. Thank you.
Thank
Questions
you.
from
Minu Singh, please.
Thank you very much, sir, for your disruptive talk. In fact, I had listened to one of your talks about 15 years ago at PGI Chandigarh,
Oh,
where you had predicted the
I
use
mean,
of.
I'm an old man. I'm 82 now,
Yes,
so
sir.
I believe you.
So that was about prediction of mobile technology becoming the backbone of healthcare, which has actually happened today. And today you've talked of so many other technologies and artificial intelligence, which is now coming up. And we have these several centers of excellence for artificial intelligence, which have been created by the government as well as in the private sector. So we actually had validated the Bhabha Atomic Research Center, innovated ECG, the tele-ECG, which was there, and the telespirometry. And there were also Dr. G.D. Jindal, he was developing a transdermal sugar assessment, blood glucose assessment. What I mean to say is that, as has been just been told, that all these needs validation to become trustworthy. And we have been talking of evidence-based medicine, and now we've started talking of value-based medicine. And there comes in the value of health economics or cost effectiveness, it's accessibility, equity. Everything has to be seen with an equity lens now. And I was just reminded of your first slide, which you had today, of the two ladies who have mobile phones. So we do have equity, I guess, and accessibility now, which can be predicted. Just to have your comments on this.
So just so one comment I'd like to make. You saw that in all presentations, I showed US FDA certificates, CDSCO certificates, CE certificates, and all that. Despite that, the medical fraternity wants validation through pilot plants. It's a matter of trust. There was no slide that was shown where validation has not been done. It's a matter of trust. And like it was said earlier, ये इतने सस्ते में कैसे होगा? I think this is the disruption. That's why I'm using the word disruption. Because, I mean, like I priced $1, non-invasive test, etc. No mammography, no radiation, nothing, etc. It has gone to 20 countries. And Lancet has highlighted it as the best. I could not present that. Yeah, that's a complete disruption. Okay, but acceptance, once again, US FDA certified, but acceptance. I think it's a mindset change that we all. Thank you.
It was a treat, sir, to listen to you and the way you have been able to find these people. I think the credit goes to the foundation as well as you, they would not have been found easily. And to recognize them was a very, very unique and uh, I wish these lectures by you are heard by more doctors and they are all inspired by you. I have only two submissions. On behalf of the National Academy, we are very privileged and we would try and find a way that if all these 14 could be inducted as associate fellows of the Academy, so they will continue to uh, enrich the Academy. I will like them also to be present on a forum sometimes, maybe in the near future. And I also assure you that we would do the best to test, validate these in subjects, patients, my own and in my colleagues. But
Thank
one last thing is salutations, and you have to complete 100 years. Never use the word old man. You're the youngest of the lot. Thank you.
you. Thank you very much. Thank you. Thank you, Shiv. Thank you. So kind.
Many thanks for such a wonderful talk, sir, and creating the Anjali Mashelkar Foundation. I would like to ask you and request you that if you can also make some kind of incubators which can handhold the researchers, because as a researchers and scientists we have many small datas which really go waste without any kind of this, and if you can create the I mean subdivide this foundation with the incubators, that will really help all of us.
Thank
Thanks,
you.
sir.
Thank you. Thank you very much. Thank you. Privilege.
I'm Professor Shiv Gautam from Jaipur, sir. It was an eye-opening talk. I keep talking to many groups all over the world, but what I found here is going beyond and opening the new horizons. Because we medical doctors keep ourselves limited within the boundaries of medicine. And this, what you as a social scientist have gone to the fraternity of medical people and gone into the innovations. I think it's eye-opening, and I support what Dr. Sareen has said. We should have interaction in different sectors, and that is how humanity can be helped. Thank you very much.
Thank you very much, Dr. Mashelkar, for this excellent talk and the opening eyes of all uh, the the audience here. And I'm sure all these young innovators who have done so great things, they are, once they become the associate members, they will be not only the academy will get enriched, but also their innovations will get spread far off.
Thank you.
With this, thank you very much, sir, and we close the session.
Thank you.
I thank all the chairpersons and speakers for sharing the wealth of knowledge. I request Dr. Kuldeep Singh sir to felicitate our chairpersons. Kuldeep sir, please up. Thank you, sir. So, by continuing to the next plenary session, which is on strategies and reforms in postgraduate medical examination, I request the chairperson, Dr. Velu Nair, President-elect NAMS.
Recording stopped.
You're welcome, sir. Now I hand over the session to Dr. Velu Nair, sir. Thank you.
Hello, check. Thank you very much. Those are wonderful sessions that we just witnessed, and I think we go on to the business end of the morning, and we have a talk on the strategies and reforms in postgraduate medical examinations, and we have Dr. Abhijat Chet to talk on this, who you all know is the President National Board NBE, and he also is an eminent qualified cardiothoracic surgeon who qualified and practiced in UK, and he also is the Director of Medical Services at Apollo Hospital. So without wasting any time, I request Dr. Abhijat to deliver his talk. Thank you.
Yeah, namaste and very good morning to all of you. First of all, I extend my gratitude to NAMS on behalf of the National Board of Examination for this interesting topic. I will be brief with the presentation. Our big brother NMC is here. Please don't take it separately, because the most of the challenges and opportunities are same for all of us, and many of these are my personal views, which you can take it, and you can pardon me if you feel that this is not right. Let us start with this one. The first is the current volume. As we all are very well aware that there is a one challenge is a quality and quantity and quality. The quantity means the numbers. Everyone feels in the profession that why we are behind the numbers. And there are a couple of factors for behind the numbers. This is the actual numbers which we got it from NMC. 115,000 approximately plus seats in the undergraduate, while postgraduate is still staying at about 60%, because of these 60,000 approximate seats, there are another 15,000 from the National Board of Examination, our DNB seats. So it will be around 75,000, 70 to 75,000. The reason why quantity is so important, quantity is so important is we have to understand that unless you don't have a required number, how can you quest for the quality in the medical education? And this is exactly the voice of experts, that first to achieve quantity, of course, not by diluting the quality too much, get an optimum baseline quality and try to get the as many numbers of seats as possible with to achieve the WHO ratio. That is number one. And second most important, which every expert accept, is what we call it UG and PG ratio, the equal ratio of UG and PG. This is very, very important, because most of the Western countries are higher postgraduate students than undergraduate students, because undergraduate students are not allowed to practice medicine there. They are not licensed to practice. Surprisingly, we are following the British School of Medicine, and we have still not adopted this approach that our undergraduate student, rather than practice, they advance into postgraduate, and after that, if they practice, that is the best way of getting the better generation of doctors. But at least to achieve this, we need a UG and PG ratio equal. Means every undergraduate students should have an opportunity to become PG doctors. Lot of challenges even after the quantity is achieved, which I will discuss after this one. Another thing which you have seen is a diversity and dichotomy. The diversity and dichotomy, why it is so important, as you have seen that 64% of medical college is situated in southern and western region, while 65% of population reside in north and east of India. So it's a distribution is not as per the population standard, and this is exactly what is creating a problem for us. Despite we have been best supply to whole of the world, the best medical expertise, even the best healthcare expertise to the world. And this is where we always face the criticism of that we have. So why we have so many issues with the medical education and why we have so many issues with the access of doctors around the country. So this is the ratio, situational analysis, where WHO recommends a ratio of 1 is to 1,000. What we are having at the moment is 1 into 834 in India, while 1.7 is to 1,000 is the world ratio of doctors around. The next is the challenges. I will go with the challenges straight away. The first challenge which we are facing with the medical profession at the moment is aptitude versus the uh, attitude or aspirations. What happens that for a long time, the parents and the society always wanted their children to become a doctor, even without checking their potential, that is it the right aptitude with them to become a doctor or not. And forget about the society, but when they come to the medical profession, when they advance into the postgraduate medicine, we still are not assessing or analyzing through the aptitude that they have a right aptitude to do the right job. And exactly this is where we are facing the problem, that we wish to produce a lot of doctors around, but is these doctors are sufficient to meet the national requirement for the healthcare requirement of the country or not? That is exactly what we wish. The urban versus rural health. As yesterday, I was talking to my colleagues that we have been trying so hard that the best access of doctors should go to the rural health. Uh, if possible, we have achieved a lot of milestones in urban health, and certainly huge healthcare facilities, state-of-art healthcare facilities, not only in private sector but in government sector also. But the major problem is still our rural health is lacking significantly, and there is always a question that why this is happening. They always give an example of Western countries, example of UK, USA. I spent my substantial time in UK medicine, and I know the fact that the major difference between the urban and rural health is there is uniformity there. And the uniformity is such that living standard, the conducive environment for the doctors, for the clinical work is as equal or even better than the urban population. And hence, the doctors are attracted to the rural area to do the clinical practice, which is not happening here. And that's why many of our genuine efforts are failing despite, and policymakers' efforts are failing despite the best possible innovative solutions. And this is something where all the stakeholders and government has to work out how we can uh, get a solution to it. They thought about the simple solution of overspilling the doctors will go to the rural health, but this is not happening, and it is not going to happen that easily. The next is the increasing cost of medical education, which is a real worry. It doesn't matter whether it goes to NMC or it goes to us. Even our hospitals who are running the DNB programs also face a huge problem of funding these doctors, their doctor stipend. And this is something where we need to find innovative and cost-effective solutions for the medical education. Diversity dichotomy, I've already discussed about. The most important other part is integration. What we are having at the moment, we have two parallel systems, the public healthcare system and the private healthcare system. Both are working well within their own capacity, their own objectives. They have shortcomings also. Having said that, we have never integrated them effectively for the purpose of medical education. And the biggest problem for us is uh, in last decade, the private and corporate healthcare has increased exponentially across the platform and across the nation. And you can see that lot of good faculties, lot of good talent, the best of infrastructures, and these all are getting drained into the private sector. Why we can't utilize them, these resources, for the best of the medical education? And this is something where we need to think about all stakeholders. I'm saying the all stakeholders have to think about how best we can integrate the public and private healthcare. I remember a couple of years ago, there was a question of merging the national board and NMC. But here, what we need is a functional integration, not the structural integration. The organization which has matured to the best of their ability, let them stay as it is. But how best the functionally we can integrate together to ensure that we can get our medical education far better and far more effective. We have a lot of solutions from within which we can explore. Then the change mechanism, there is always a tendency to change. And we found it more difficult because what we have seen the gold standard of our old system of medical colleges, and we all grown up from there. So we feel that how the private hospital, private healthcare or private hospitals are going to serve or going to take part into the medical education. This is something possibly we need to understand the dynamics, and we need to be ready and to brace for the change. Unless we don't brace for the change, we won't be able to bring the integrated solution, effective solution. Then comes the learning resources. Until now, even in at least for in our when we were studying the postgraduate education, the major medical way of education was physical education, which was on site, directly under the supervision of faculties. Now, the lot of things have changed since then. The technology is rapidly advancing, much more rapidly than we are thinking. The complexity has increased much more rapidly than what we are thinking about the field of medicine. And this is something where we need to work out. And what we in the national board, what we worked out is a phygital education model. This model is beyond the physical education, and this model is supplemented by skill education, skill and virtual training. It compensates for competency-based education. And the third way of education is a digital education. Digital education, we realized the best potential of digital education during the COVID time. And since then, at least we realize that the digital education can bring the uniformity, some sort of uniformity in the medical education across the board. Uh, but I must say that still the physical education is gold standard, and skill and digital educations are largely complementing. they cannot replace at the moment, irrespective of artificial intelligence or whatever innovation. I don't think so. In a few decades, they are going to replace the physical education, but they can certainly complement your physical education. Overall, it increases the scope of medical education, and it reduces the period of training for the doctor, where they progress from knowledge to the practice. Other thing which we realize, which is common to all stakeholders, is a faculty shortage, and we need some out of the box and innovative solutions. How best we can find a solution to the faculty shortage. These problems we are also facing significantly in the National Board of Examination. The last one is the syllabus versus curriculum. We know that these two words are different, and whatever the syllabus which we decide and what the curriculum is which we are building up, there is a lot of discrepancy between two. I'll give you a simple example of undergraduate. This one, although it's not our subject directly, but we in undergraduate in our time we used to study big books of Harrison or big books of medicine and others. They have almost 1,000 plus diseases, while as a basic medical training to become a good MBBS doctor, we need to learn the common diseases which is occurring in India, which is 200 to 250 diseases. And instead of focusing ourselves into this, because the syllabus is so high, the students, the generation of the students get confused that what they are going to study and what they are going to learn as a doctor before they get it into practice. So this is something which we need to give a more better integration. So these are the challenges. In National Board of Examinations, this is the current stage of our accreditation. Only one additional issue with the National Board of Examinations compared to NMCs, we are running a lot of FNB programs which are not approved by the NMC, but they are only meant for the skill enhancement. And this, we have 41 programs, but they are mainly meant for skill enhancement, and they are this is meant for subspecialty development, and it's just to complement your postgraduate medical qualification. So that we need to take it on the account. These are the distribution of our seats at the moment. We are almost at the 15,500 to 16,000 seats at the moment. This much of doctors have been qualified the DNB and DRNB exam, which is super specialty in last 10 years. This is just a general visionary concept of National Board, that what we need to do with our focus on medical education. Assessment is one of the most important part of having a good training. And this is, I'm just giving the example of the assessment and performance. A lot of things have changed than before. We are continuously looking at improvement in the examinations quality, assessments quality. It has to be student friendly. It has to be well aligned with the NMC, and to make sure that the better the assessment process, certainly you will get the better training outcome, doctors with a better training outcome, because that will be the end point of any training scheme or requirement. The unanswered questions, as we have discussed, that are we maximizing our resources effectively from medical education viewpoint? Do we need to rely more on the self-regulation? Self-regulation was the key in older times when people used to regulate themselves easily. What has happened, that complexity of medicine has gone so significantly high, that at the moment we need a central regulation or we need an objective regulatory parameters across the board. And this is exactly what is about the self-regulation and what is about the extending or what you call it a strong regulatory mechanism for the and without having a good regulatory framework, you are not going to expect the best outcome from doctors. This is a requirement. This is a typical requirement to ensure the human biases is minimum in medical education. Do we have evidence-based support for new learning approach? There are many new learning approaches has been described and has been explained, and in many conferences and many forum people are mentioning about it. But are these approaches suits to us, suits to our requirement? This is something which we need to work on it. There are many stalwarts here, and certainly the input from them will be very, very useful that how best we can advance ourselves with the innovative approaches and how best we can achieve what we want in the for the betterment of medical education. The other is how we are going to address the faculty shortage. Do we need to bring our old honorary uh, consultant scheme back or not? There are a lot of unanswered questions. Like people like me, I was studied under the honorary honor doctors only, and they trained me very well. And so I couldn't see them that a difference is between full timer and honorary of my times. But since then, this differentiation has been made. All the honoraries has been got out of the system, and that is the reason where you have a huge faculty shortage as a faculty. So how best we can address it? That is something which we need to look at it. Curriculum I have already discussed. And do we able to create doctors to fulfill the objectives of the universal health care? As I said that we are here, there is a dynamic approach is required. What happens that uh, we give uh, specialty accreditation, but we don't understand. Like I remember in my time in UK, we have only 60 specialist consultants posts were available and 200 consultants were ready to go on job. Nobody, many of them, the best talent couldn't got a job and they have to become a staff grade. So dynamic approach is a better approach where every specific interval of time, we must review our accreditation system that what is the current need of specialists across the country. We need more broad specialists. We have to increase the pool of more broad specialist training. We need more super specialists. We have to increase the pool accordingly. So it has to be more dynamic approach rather than a static approach. This is something which we need to work on it. The next one is the opportunities, which I'll discuss. As I said, we must go to achieve the 1:1 UG and PG ratio. That will certainly reinforce the training, quality of training. That will certainly improve the overall healthcare scenario across the country, and there will be less criticism about the medical education which we are facing these days. We need additional 75,000 PG doctors by 2025. I think this is a MOHF normally projects based on the population metrics. Faculty pool, we certainly need to increase. As I've mentioned, we need to make it more than double. Emergency medicine and family medicine, this was something I was talking about. Why we can't make a best use of our emergency medicine to ensure the rural areas can be best covered during the time of need or crisis, how we can modify our education into the emergency medicine and family medicine to ensure that the rural areas are best covered with it. The training resources requires accessibility, availability, and uniformity, whether it's a skill or virtual training, whether it's a digital education, or whether it's a physical education. We need to ensure that enough training resources should be around to bring the uniformity. The professional curriculum these days is very vital as we all are facing this West Bengal issue. This professional curriculum is about medical ethics, about the quality into the healthcare, about the doctors and patient communication, about the learning with empathy. Uh, all these things are very important, and I'm not surprised. In July, when I met the ECFMG chief in USA in API conference, he mentioned in a formal forum that communication and clinical research should not be considered as a collateral specialty or pathways. They should be considered within the clinical discipline. And the newer ECFMG examination is going to include these two things, which is a communication and clinical research into their assessment system or criteria. Career trajectory is also very, very important. Like family medicine, we have miserably failed to increase the number of family medicine because there is no career pathway for them. Students always look for the career pathway. If they have no career pathway, while they will go to the family medicine, more than half of the seats goes empty in the family medicine. So we need to create a career pathway for them. We have talked to the government and we keep talking on this time, these issues that without that we won't be able to. They always talk family medicine looks very good to discuss in a major forum, but we need to understand that we need to create a career pathway for them. Otherwise, we will not get what we want with these specialities. And research and innovation, we need certainly very increased focus on this. And we need to build up a culture. I always I always give an example of two like AIMS Delhi and the Gangaram in private sector. Why they produce so many clinical research publications and papers? Only just because they have built up a culture within their system. So all the students who are coming, they adopt this culture, and certainly right from their in the initial formative years, they go with this culture, and this is the biggest advantage of building a culture of research and innovation within your system. And dynamic approach I have already discussed about. The NB reforms and our current role is about enhance opportunities in the private sector, which we are doing it. We had now 1,700 organizations working with us. Previously, it was less than 1,000. We have still a huge scope, but we want to make sure that we go slowly and in a measurable way to ensure the quality doesn't get diluted. National entrance examination, we need to continuously improve on that. And certainly the next is the pathway, which will be eventually come. But till then, we have to ensure that at least the entrance examination, we have to make it better and better every year. And we have to learn from our own shortcomings and own experiences. The NMC approved courses, we normally align with NMC with most of the courses. So something which is not acceptable to them, we will not be going for that. Continuous improvement in exams, I have already mentioned. E-learning platform and webinar classes, we need to make it more just to supplement and complement our physical education. I said that it's not going to replace, but certainly it will be helpful to the student. And it's a more uniform way, as well as it provides a global connect. That is the best advantage of it. International fellowship we have started. We are still in the pilot project. We need to get better with it. Annual review and formative assessment. Formative assessment now we are focusing on. It's like an internal examination in the medical schools. It was more a formality, but now we want to make it more better for the students. Expansion of accreditation to include government institutions where NMC criteria is not fitting to them. And we have developed our e-journal and we are aiming to get indexed in a couple of years' time. And we have started the faculty development program, which is mandatory for all new faculties. And so we have started the Communicon program to ensure, and we published the good practice guideline to ensure that we increase our focus on uh, professionalism, communication, and research. The private healthcare opportunities, I'm just mentioned the first is American School of Medicine versus British School of Medicine. American School of Medicine uses private sector for the training purpose. Like HSA is the big private sector, and they are having a formal residency program across their hospital across the world. HSA is one of the biggest private employer in the world, and still they run the state-of-art residency program. In British School of Medicine, this never happened because the British School of Medicine was largely an NHS program, and there was hardly private system which used to happen there for the local community. So that's why the British School of Medicine never adopted the private sector hospitals or BUPA hospitals for the training. Why we are in between the American School of Medicine and British School of Medicine? We have to adapt the pathway which is more suited to us, and it is more innovative, and certainly it stays with the time. That is what is most important. The functional integration, as I mentioned, encourage more clinicians to take active role in the teaching. We need to find an innovative solutions to create more and more teachers. Potential for preclinical UG training. This is something in private hospitals. This can also reduces the cost of medical education. But again, this is a very, I will say, this is a very difficult statement because people will say that why you want to change our system. We are not here suggesting these are the views that we don't want to change our system, but so many wonderful private hospital setups are around. And why these hospitals, some of they're based on riders and regulatory mechanism, and integration, why some of the hospitals cannot be utilized for preclinical training of undergraduate doctors. Certainly, you will produce the better undergraduate doctors. This is a thought process. I am not saying that this has to be done as we are doing, but this is a certainly uh, something which is out of the box solution, which we all stakeholders need to think about it. Utilization of infrastructure as best as we can utilize for the learning resources, recognition of private sector faculties, and active participation of the private sector into national strategy forming. This is what the private sector opportunities are there. And the way forward is again the more or less same. What we need is better integration, better innovation, and strong implementation. The three I's are very important. We need to move on the competency-based curriculum, which NMC has already got into it. Inclusion of professional curriculum, uniform exam system, which next is the right way to go for it. Incentivize the research and academicians much better. So it built up the culture within the organization and create opportunities for the young aspirants. Thank you so much. Thank you.
Thank you very much, Dr. Abhijat, for that wonderful overview. You have touched on just about everything, and you've also given solution and approaches which are innovative and indigenous. So, I think such an important topic, and I think, before we invite some comments, I would just like to say a few things. First thing is on the challenges which you face. Our strategy, the postgraduate medical examination, skilling is a victim. That's been the observation across in most of the places. And the reason is that one of the reasons is our undergraduate student, when they pass out, he doesn't even apply himself during his internship period. He's preparing for his PG in his internship. And after his PG, he's preparing for his DM. So he comes to DM very underskilled. And that is why some gap between these are required, so that he goes into the field and does some practice. But that's not there. He can go straight into the exam systems. This is one thing we need to think about. That is a big challenge, skill. Number two is about the curriculum. Now, the change for the need is no debate. The important is who changes the curriculum. So if you get a round peg and a square hole, it'll never fit. So you have to get the right people to change the curriculum. Very often, it's not the case. And so many specialties have suffered because of that. And I think that is a need of the hour. Number three is, you said for family planning, we found this in the armed forces too. There are no takers. While it is a very good specialty, you see in England, in NHS, the family practitioners are the backbone. So really speaking, in the career path, they do all specialities. Why can't we make them eligible for DRNBs in different some specialities, which is mostly their practice? So it's a serious consideration, importance, because you won't fill your seats, and it's the need of the hour. So you must have a career path for it. It's unfair otherwise. And then you said about rural and urban. You know, we are urbanizing our rural areas. You see the NCR, many villages have been taken over. So those people are getting benefits. So what we said, 80% in 80s has dwindled down to definitely a smaller percentage. But what's important is to incentivize. And you brought that out beautifully, that unless you incentivize and give that person some incentive to go to the rural area, he tries his best to escape it. So we must create those incentives. Now I will invite Professor Shiv Sharin, and then after that, Dr. Sanjay.
Thank you. It was a very nice presentation, and I was impressed that 1,700 of the hospitals have NBE programs. And I look at it, the medical colleges, maybe 720 odd medical colleges. So you are like 2/3 of medical education and 1/3.
2/3 are them. We are 1/3.
Yeah,
But
17.
we have involved the smaller organizations. That's
Yeah,
why.
but it's a very big reach that you have. I'm not saying what I've message was that we should standardize whether it is NBE and whether it is
Yes.
NMC, and it is time that we should have some kind of a integrative pathway, because ultimately it is the doctor who has been produced in India what will matter. So even earlier, my suggestion and today is a very fortunate day, so many directors of AIMS, NMC and NBE both here. So the standards for entry, standards for exit, and monitoring, if that can be standardized, it doesn't matter where you study, who teaches you. Ultimately, it is the product.
Yes.
And thank you for bringing this to us.
Thank you so much.
Thank you very much, Dr. Sarin, for those valuable comments. Yes, Dr. Sarin.
That was a wonderful talk,
Thank you,
sir.
sir.
So, looking at the government institutions, sir, everybody's aims for an MD/MS programs. The NMC has defined set rules, which takes time. Now, these institutions go for a DNB program to start off with, which the national board approves. So, are we creating a different standards where we're looking at them getting approved on a fast track from a national board, vis-a-vis the MD/MS program, which does take time with the NMC? And the second question is, are we creating two sets of cadres of trained doctors in the country, one for the private sector, driven by the private sector, and one driven from the government institutions, with the DNB program vis-a-vis MD/MS?
Okay, let's take it in this way, that eventually what is going to happen uh, uh, in my institute, when we take doctors, we are not worried whether they are MDMS or whether they are DNB. We go by credentials. And eventually, what is going to come in the final selection of doctors is a credential. So now why MDMS is so important and why DNB is so important, I'll tell you simply. What happens that the areas where private healthcare has expanded significantly, where usually DNB students or DNB doctors gets an easy access to the private sector hospitals for practice purpose or for other. But there are states where private healthcare has not developed at all or developed very less. In this area, MDMS is far more important because in government job, although there is no partiality or there is always a human bias, the subjective bias you can't eliminate because governmental job, largely the MD and MS takers will take, very few private takers will, DNB is going to get a government job. So this is number one. So where the corporates and private healthcare is less, usually the liking for MDMS is far more higher for them, number one. And second is where the private sector is there, usually they are not worried about whether they are DNB or they are MDMS. This is what I would say about it.
Sir, I've seen in the state of Uttar Pradesh, they started a medical college. The MDMS is going to take time to start. You go through the DNB route, have your postgraduate program start. In parallel, you apply for the NMC, which is going to take 2-3 years time, or even now they've cut short the time. But then everybody's pushing for a thing, and then they say that we started a DNB program. So are we having different standards which are of accreditation and approval? Because the DNB has said yes and the NMC has said no.
It's not different standard, but what happens is NBMS is a flexible arm because NMC has lot of restrictions because of the act and something which they find difficult to go beyond the act, while these restrictions are not with the DNB. Now, second, let's take a equivalence. Now, equivalence is different. DNB courses are equivalent, but on certain regulations and riders by NMC. It is not blindly folded equivalence to MDMS. There are certain conditions on which they are equivalent to these courses. Second, take an example of British system. They have 4 royal colleges. You are a fellow from any royal colleges, but they have standardized, as Professor Sarina stated, you standardize the courses in such a way that it hardly matters where you are from. Now, little bit of subjective bias you can't eliminate because that is going to happen. So, but that doesn't come in the way of your progress at the end of the day. That's what I would say.
We are over time, so please come, Dr. Behra and Dr. Sharma. Just
Yes, I'll
make
give you a
quick-
very brief comment. Sir, very rightly you have brought out various issues. I'll just confine to one issue about the quality of teachers and the faculty. You see, unfortunately, with our enthusiasm, the country, yes, we know that the country needs more doctors, more, whether they are specialists or generalists, whatever you call them, but nobody gave attention, including the government, that who is the teacher, not only the quantity of the
Yes,
teachers,
I agree.
it is the quality of teachers. That is also important. Both the quality and the quantity suffered. So I think we need to find a way out.
But there's a
as
struggle for both.
Yes.
There's struggle for us, there's a struggle for NMC.
So then the question is,
Yeah.
where is the solution? We go on opening medical colleges every districts.
Yes,
So these are, I think we have to raise
Yes,
our
we
voice.
need to find
We
some
have to
out
tell
of the
that. So number
box
one,
solution.
one thing, because I am standing here, just tell what should be the role of NAMS. We are also part of the system, sir. So one thing, obviously, we'll try to impress upon the government, including, sir, yourself, also to the NMC, sir, you are sitting here. So the issue of this thing may be because of different reasons we are not able to tell. The government wants something, because that is not always desirable. We have to maintain a balance between the two things. And secondly, to help the country and to the national board or the NMC, we need to take up the training the teachers or the faculty.
Yes.
That can be one job which the NMC can take up, and that with the help of once we take it up to our the first EC meeting, we'll take that up and we'll see how that is done. And just to give an additional point, that so many CME programs, navigate programs, they are being introduced, they're being done routinely. So why not the NB students or they are taking part in that? So somehow you have to make a synergy there.
So we can create a credit system by which actually which everybody agrees, then it can be a credit system. So the top people are taking these CMEs.
Just to, just to keep the ball rolling, what the Dr. Professor Vera has said, I just quote an example that in one of the private hospital, the guy, when I joined that hospital, the guy was a resident and he qualified. And after that, he became the teacher. He had never been a teacher before. And he is the only person who is training the DNB students in pediatrics, a very major branch, only trainer. And so we have to find something about the, not only about the students, but about the faculty also. One person giving DNB in pediatrics, we have to think very seriously about it.
Thank you. Yeah, the last comment.
Good morning. I'm Dr. Shakti Gupta from AIMS Jammu. We have started, sir, three programs, very new program actually we have added over there. One, we have started a joint PhD program with the IIT Delhi in of area of interest like health technology assessment, innovations, medical devices also. Where the faculty is from, one faculty is from AIMS Jammu and other faculty is from IIT Jammu. And our faculty is working in the area of artificial intelligence, how we can apply in medical science. This is one area we have started. Second, we have started a MBBS PhD program with IIT Jammu because all MBBS students may not be interested to pursue for the post-graduation. So we thought there should be some opportunity. These can work with IIT and register for the PhD program. This is another we have started. And another program we have started that is a MBA in Hospital Administration and Healthcare Management program with the IIM Jammu and IIT Jammu, where 1 year teaching is being done by the IIM on management aspects, 9 months with us, and 3 months with IIT. So this degree is going to be signed by all the three directors actually.
Yeah.
So that we have now introduced, and the demand is so much, sir, actually. Because
Actually, point is well taken, and I'm sure we can continue this discussion at tea. But this is such a wonderful topic to discuss. There'll be no end. Thank you very much, Dr. Abhijat. Thank you very much, all the people who came and gave very valuable comments. And I think with that, I hand over to the organizers for the next session.
Thank you, sir. Thank you for the very nice brainstorming session. So I request chairperson, sir, to felicitate the speaker, sir. Dr. Abhijit said, please welcome on the stage. Now I request Dr. Shilpi Dikshit ma'am to felicitate our chairperson, sir. So for the next plenary session, which is on reforms in postgraduate medical education, I request the chairpersons, Dr. Shakti Gupta, Executive Director, AIMS Jammu. You're welcome, sir. And Dr. Sanjeev Mishra, sir, former Director, AIMS Jodhpur. You're welcome, sir. Thank you, sir. Now I hand over the sessions to our chairmen, sir, chairpersons for the proceedings. Thank you.
Good morning. It's a pleasure to introduce our next speaker, that is Dr. Vijay Oja, who's the president of the National Medical Commission, and he would be delivering a talk on reforms in postgraduate medical education. Professor Oja.
And friends, Jai Hind. At the outset, I thank the President of National Academy of Medical Science and his team to make me a participant in this premier think tank event on health and medical education in the country. Considering this fact, I will refrain myself from talking on topics well covered during these 2 day sessions and my younger brother. Before I touch upon the academic and technical aspect of topic of postgraduate medical education, I would like to discuss the overall aspect of health and well-being, health need of the people in the country and world around, and role of the government. As all of us know, Government of India came out with the first health policy in 1983, second health policy in 2002, and the last one in 2017. The founding principle of this health policy have been the same, like health for all, reduce disease incidences and mortality rate, and some shift in target from communicable disease to non-communicable disease as significant success in eradication of the communicable disease were achieved, though this myth was broken by COVID-19. Initial years have gone for establishing the healthcare system like public health centers, community health centers, various disease control programs, etc. But as days pass by, demands have also increased for better care and cure. While newer challenges like problems of man-made organisms, resistant strains due to rampant unindicated use of antibiotics, environmental degradation, and professional difficulties, causing a lot of risk in the individual life. If we go to the latest 2017 edition of the health policy, the first paragraph of the goal of the national health policy tells about attainment of the highest possible level of health and well-being for all at all ages through a preventive and promotive health care. And if we go to the first paragraph of Principle of Health Policy 2017, it tells about the highest professional standard, integrity, and ethics to be maintained in the entire system of healthcare and delivery in the country. The significant importance of giving to not only the health, but also to the well-being through preventive and promotive healthcare while following highest professional standards, integrity, and ethics is visible. This is possible only if we grow individually and collectively in our consciousness. I mean the word consciousness, chetana, and not just awareness. Though all of us have felt need of this, I feel we are not sufficiently serious because it is a very Herculean task of very time consuming, and this is not being practiced in a public as well as a private sector. Sometimes I feel we are not giving sufficient time for the preventive and promotive health because sometimes we feel that it may be labeled as a primitiveness. When I, for example, my personal experience, I'll say that when I shifted to Aurobindo Ashram at the age of 34, I thought that there should be something different which I am supposed to do. And from that, since last 40 years, I have not taken a tablet of paracetamol or antibiotics. And looking at me, my wife also has not taken a single paracetamol or antibiotic in last 30 years. So her genes were different from me. This kind of a different thinking we have to think and start a different preventive and promotive health need of the country. Now, considering after this initial few opening remarks, I will now go to the topic of the postgraduate medical education in the context of the role of the National Medical Commission. Being the elite people in front of the meal, I tell you once again that I will restrict myself to the regulatory role and regulatory mechanisms by which we can make whatever difference possible. The Act of the National Medical Commission provides for the quality of affordable medical education, equitable and universal health care, promote national health goals, encourage latest medical research, and enforce high ethical standards and maintain national medical registers. So these are the preamble of the National Medical Commission, where ethical standards, research and register, and equitable universal healthcare availability are the requirement of the National Medical Commission, all by transparent and method of assessment of the medical institution and other processes. As you are aware that there are 33 members of the National Medical Commission. Out of that, 10 are the ex officio members, and then remaining 10 are the part-time members. Out of them, they are either nominated by the state government as the vice chancellors of the various universities or elected members of the state medical councils. It comprises of the 30 members of the National Medical Commission. Out of that, one is a chairman, and the 4 board presidents are also the ex officio members of the National Medical Commission. The selection of the National Medical Commission member is by a search committee headed by the cabinet secretary of the country. Now I will tell some of the salient features of the National Medical Commission Act, and because of which probably some of the questions will be easily answered and how to go forward. The National Medical Commission Act has been created with very intelligent think tank of our country, and it has given a provision for a very able guidance and control of the government of India. The section 9.6 of the National Medical Commission Act says that a person who is aggrieved by any decision of may prefer an appeal to the central government against any decision of the National Medical Commission. This is a very encouraging decision, and by that, any decision of the National Medical Commission can be reversed by the central government. The another section is the section 45. Under the section 45 of the National Medical Commission, there is a provision that the central government may give any direction to the National Medical Commission as far as the regulation is concerned. So any regulation formed by the central government may be altered by the central government and at any given time. These are the very important features about the National Medical Commission Act. Now I will go to the aspects of postgraduate medical education regulation which are there, and what are the newer issues which we have taken up in the postgraduate medical education regulations. All of you will be interested to know what are the changes that have happened over the years, since the MCI has done its wonderful job. MCI was made up of a very great think tank. One of them is sitting in front of us, and they have done a very significant contribution over the years. The NMC is a continuation process. We have continued whatever good things they have done, but only one difference that is there, which is apparent, is that the National Medical Commission, they are full-time members. The government of India has appointed almost 13 full-time professors, professor level people to be there continuously and not the part-time activity. And that probably may make little more difference than what was possible at the MCI time. This is the one thing that I would like to tell you. And then as a part of that, we started working since 2020 and 4 years, but initial 2 years gone in COVID. Subsequently, the serious process of starting the regulation started in 2022, and we came out with almost most of the regulations in 23, start of the 23, and some are still pending. So the process is very much time consuming, and the process of the postgraduate medical education took a fairly long time, and we came out with that regulation in January 23. And in this postgraduate medical education regulation, the first section which we are saying is that we have defined what is qualification. We have been thinking the difference between the qualification and a course. There was not the process of giving the qualification was done, but then there was no regulation how to decide what qualifications to be granted. So this special regulation called recognition of the qualification regulation was enacted by the National Medical Commission first time. It is slightly different from what was being practiced earlier. According to the new regulation called is the recognition of the medical qualification regulation, we have defined the various qualifications which will be recognized in the country as, for example, and the process for recognizing those qualifications. For example, at this juncture, at the post-graduation level, we have 86 postgraduate qualifications. We have listed them in a proper way. And previously, there was slightly even confusion whether M full stop, D full stop, or MD. All the things have been properly written in the statutory way so that there is no ambiguity at any level. And we have defined the process of including any qualification in this. The process in this regulation, the guidelines are that if any new qualification is to be done, then it should have come out of the sufficient, significant academic rigor activities. It should not cause confusion in the minds of the stakeholder, etc., etc. So there are around 5-6 guidelines we have defined, and based on those guidelines, any new qualifications will be included, and that will be a continuous process. While doing so, we have also felt the need that these postgraduate, postdoctoral certificate courses and PDF, these PDF and postdoctoral certificate courses are a very important part of our training program, and they are not considered as an additional qualification. We decided that these are also considered as an additional qualification, and whatever the list of the postdoctoral certificate courses or a PDF which have been approved by the process of this recognition of a qualification regulation will be considered as an additional qualification in the list of the doctors, and that will be sufficient for them to work in the court of law. So this is what the hindrance previously. Now we have 4 types of qualification: MDMS, PDCC, PDF, as well as the uh, uh, DMMCH. These are the 4 things. In future, we will understand gradually that PDCC is equivalent to MDMS or DMMCH, and PDF also is equivalent to DMMCH. Once we will go into that culture, this is been decided based on the thing of need. When the program needs a smaller period of training, it is a PDCC 1-year course. Because we are already having a list of the PDCC, we continued with the terminology. When the program needs a 2 years training program, it will be called as a PDF. And when it is a 3 years training program, it will be called as DMMCH. So this part we have already addressed very well, and anything which requires a 3 years program can definitely be included by following those processes by expert committee. So these new regulations has been included in the postgraduate medical education regulation, and the list whatever been recognized in this recognition of the qualification regulation has been included in this PG regulations. Another few reforms what we have done in the PG regulation is that there was a confusion all the time that the permission and recognition. Then initially it was considered that the institute will be recognized once the first batch is due for examination. This kind of a thing was confusion, but because when the seats were increased, then some students were admitted on a permitted seat, some students were admitted on a recognized seat. Probably this kind of a thing you might not have faced. And this was causing confusion in the minds of the people. In this way, we decided that once permitted, it is recognized. However, how to maintain the standard? Once if we remove the recognition process, the standard will not be maintained. So for that purpose, we enacted another regulation is called Maintenance of Standard of Medical Education Regulation. By this regulation, every year, all the institute will give their data to the postgraduate medical education board. This data, we have redevised the standard assessment form. All the standard assessment forms have been redevised. Please go through on the website. And we are going to further work on those quality of our standard assessment forms. And they will give the forms, and then based on the requirement, the PG board will do the certain inspections and recognize them annually. So this is what the process we have decided, and this is a little bit changed than what used to be there in the previous regulations. Apart from this, these things, in postgraduate medical education regulation, the few other things are that we have introduced the training of the cardiac life support system compulsory for every postgraduate. That was the thing, and then other modules like ethics, etc., have been included. District residency program, we have done some minor changes. But one of the important change we have done in the examination is the inclusion of the MCQ type of exam, which was not there previously. So this, instead of exclusively a theory type of a question, we have left it open for the universities if they want to change over to MCQ type of a questions to improve the objectivity of the examination. As well as we have included the OSCE for the thing. Regarding the dissertation, we have been little bit lenient on the students at one aspect, but little bit stricter on the other aspects. We had a lot of complaints that based on the dissertations, few students committed suicide. And from that point of view, we have decided the dissertation will carry 20 marks in the practical examination. So it will not be a compulsory if his guide doesn't sign the dissertation. Even then the student can submit the dissertation to the university, and he will not be prevented from appearing in the exam. But there is a catch there, that the external examiner will examine his dissertation, and 20 marks of his dissertation will be there from that. So that from there we have made it more accountable. With this few reforms and etc., I complete my presentation, and I thank you very much for the organizers to giving me this opportunity.
Sir, just want to share. Since actually I was heading Department of Hospital Nutrition in All India Institute of Medical Sciences, Delhi, and for about 8 years, actually what I observed that there are certain skills which are missing actually. Maybe at undergraduate as well as postgraduate level also. There are certain skills that must be addressed in the curriculum. That is the management skills actually. That is I think there is a need for including some lectures on management management skills, even post graduation as well as undergraduation also actually. Because when a freshly MBBS graduate, when posted in a rural area or independently in a dispensary or primary health center, actually, he does not know how to manage that facility actually. So I think some exposure needs to be done on that area. Another important is that we must focus on communication and public relation skills also actually. What I have observed that there is always a gap actually. Whenever actually any VIP comes to the healthcare facility or in the hospital, so he introduces in
Sir, I've just seen from President National Board of Examination, Dr. Madhavan Kar, Executive Director, Health Level.
We are taking it, and I will put some views also. Yeah.
Thank you, sir, for the question. And the question about are we relevant and what next are we likely to do for future? So we know that for quality in medical education, that we are talking about undergraduate as well as postgraduate medical education. The two are a bit qualitatively different because in undergraduate medical education, we are focusing on producing a basic doctor. And whereas for postgraduate medical education, we are emphasizing on specialized skills and the teaching, there is more hands-on. And it has to be hands-on on patients all the time. Whereas for undergraduate medical education, there have been good reforms and we need to stick to them, which is about early clinical exposure and self-directed learning. We know that self-directed learning is now the cornerstone of increasing population of students also who have to graduate. And we have dearth of doctors, of the medical teachers. Hence, the vast resources that are available on the media, all the digital media, have to be utilized in a very, very responsible way. And to add responsibility to that, we
Can
need to
I
have.
simply interrupt
Yes, sir.
for a second? Are we relevant? Are you happy with what we are doing?
Yes, sir. I don't
You are
think
happy?
there is a much reason to be unhappy totally, but there certainly is a scope
So
for
can you
improvement.
suggest what makes you unhappy? What is the gap you would like to cover? We know this is running.
So one gap has already been
So I
stated in
would
the.
request each one to be very crisp because of the time. Just add, sir, we know, all of us know what is running. Now I want to add two things, or I want to reduce the burden by two things.
So in undergraduate education, the gap is of lack of skills. Secondly, the lack of
Kuldeep, are you making notes or are we recording it? Can we record it, please? All right, thank you. Yeah.
So lack of ethics and accountability, which is leading to some very problematic outcomes during the undergraduate careers of these students, which needs and ethical and professional values. We need to
Okay.
teach them professionalism as well as medical humanities.
Co-chair has.
Dr. Basnik.
What do we do to make, as Sir said, our undergraduate teaching relevant? Everything is available on the net in some form or the other. You've got these coaching classes coming, and students prefer those forms of education vis-a-vis your classroom teaching. It's time we reform. That's what my question to it, and I think the INI should look into. Why should I come to a class when everything is available to me on?
So that is why, sir, people have flipped
Dr.
classrooms.
Biswas, please.
And,
Dr.
the
Biswas.
newer technologies which are there.
Okay, so, all right, Saurabh.
Sir, I'll just continue with what I wanted to speak from that platform.
Yeah,
I
please.
think time could not permit. So when we talk about undergraduate, postgraduate, we have two compartments to talk about. So I have a concern in our medical education system. So the system is that whenever a student joins the undergraduate course, they are not mainly focused on getting training as an undergraduate. Second year onwards today, every undergraduate student is taking coaching for post-graduation. So they're not focusing on the basic training, what we're looking as basic doctors for the
So,
country. So that
one
is
is the lack of clinical, he goes out. In fact, in the diagram, in the vision document of 2010, that there should be 80-20, so that you have starting from 20 and he goes on to the third, he adds 40% clinical. It's not happening.
Correct.
Is that correct?
Correct, sir.
So that is one, the clinical part must be dealt with the hospitals and the college.
Correct.
That is not being done.
Correct,
So
sir.
we add that. What else? Two.
So second part, sir, we all will accept in the hall that the internship program practically does not exist. So we all have come to the system when house officer was there.
Internship should be implemented
So strictly implemented. Well, I should
and
be strictly.
seriously implemented, and part 2 of the entrance exam should be at the end of the internship. Only 50% marks in the final, and the NEET exam, the remaining 50% should be given at the end of internship. This was the original plan, and I hope we can implement it in reality.
And
Dr.
so,
Yes.
third about the postgraduate component, sir.
Yes.
Sir, we are getting postgraduate students who are taking subjects by default because sir, they are not happy with the careers.
is
So
true.
we are not getting good doctors. Sir, candidates are joining postgraduate courses, leaving postgraduate courses. We are getting seats, vacancies. It's a
Yes.
big concern for the country, sir.
Getting
Because,
it by default is a fact, and we have not addressed any time in life. It's a good point. We should address it.
Sir, one point, this is my concern also here. This is like for National Medical Association. When we are talking about like the medical education undergraduate, this is different from different steps. Like for AIMS is different for INI, and the expectations of the government is different. And people, we have to keep the importance. That's what we need for the society. Like
What are your suggestions, please?
This is like 3 stages I'm telling. Like one, we have to see that is the peripheral primary health care level for the general population that cannot be taken care by this the INI, those who have been trained in the undergraduate level. Second level is the middle level. And third is the super specialty. Super specialty people never go to the periphery and they are the serve. But we are equalizing the educational system for all, every the same. But
This
expectation
is
from
a
I
very
and I,
good point. So
Yeah.
we are making all colleges ranked, assessed, and entered similarly.
Yes,
It's not a great idea. There used to be medical school and a medical college in the old times.
Yeah, that's why the post graduation we are giving importance. Everyone should be postgraduate is a wrong concept. There's a someone is not interested like this level, they should go to the periphery. They are taken care. There should be
So
training
that's
system
a
is a
national
different.
entry. You can't change that, but yes, you get what you want.
Yeah.
It's not easy. But the suggestion, what do we add, Dr. Carr or anyone? We haven't added anything new. Anyone from the audience, or I'll just want to give you a simple example of what you are saying. It was 19, probably 80s, mid 80s. I was at Cleveland Clinic, and my friend who was the chief took me that I have a class for the undergraduate. So we went at 11 o'clock. He looked at the watch, 11:30, not single student came in the class. Then he said, let's go to the library. All the students who were reading in the library, nobody attended his class. Now, this guy was sweating. And the reason for sweating was he said, I will lose my job. The teacher was afraid that he is not good enough to teach. The question is, why do they not get? Because we do not have any monitoring of the quality of teaching and the teachers. It's not the student's fault. And sure enough, this guy, after 2 years, was removed from the VA system. Just one class, and the students showed their annoyance and their unpleasant, interactions. And this guy lost his job.
Yeah,
Yes.
can I interject, sir?
Yes.
Okay. I think it's all about the quality of teachers we are having, the quality of faculties, their professionalism, their abilities, their aptitudes, their personality, their ethics, all those things. The biggest problem now coming is, sir, students are not coming to the classes. It's absenteeism because everything is available on the Google and ChatGPT. Your teacher has to be above that. So we really need to rethink that how we can deliver the assigned syllabus to them. That's a big challenge. I think we need to be more interactive. We need to make, we can put some study on this, that what is the real cause of absenteeism. Maybe 4 or 5% people, maybe the smoking and other substance abuse and all those things. This is other emerging problem. I think we should not close eyes on this particular thing.
So just a thing that if we say that we are a teaching institutions here, all of us, and we are premier teaching institutions. So within our teaching program, we have to incorporate system of teaching where it helps the student for his postgraduate entrance exam, terms of questions, assessments. There, you're teaching clinical, but for him, what matters is at the end, the postgraduate entrance exam. You may preach him anything, but he or she will say, for the postgraduates, you teach us a subject or a system, put questions relevant to it, which you are going to be asking. After all, you've got the best minds coming here. If X, Y, Z coaching institutions, which is teaching something good, take a leaf out of that, incorporate it in your system. Don't feel that they have done something and we can't. I think we should be open to take things from there and there. We did experiment with one of the faculty here Sunday, and because he had been teaching once in one of those private classes, full house morning till evening in this auditorium. So there must be something which is there. We must look at it that way as teachers, maybe rethink the way we
Yeah, audience will bear with me, sir.
Two thoughts for everyone's consideration. Why the US system in a way is better. After their first semester or first year and a half, that subject is removed. You finish off the first MBBS and then it doesn't come in the exam. The second MBBS, it's the end of it, doesn't come. And third is only that part. I think what we are doing in your final exam for the MD, MS entrance, you still ask biochemistry, you still ask anatomy, and you forget it. So one of the reforms which should be considered by all the authorities is this, that once you finish a subject, you finish, and then you go on to the clinical side. I think that part. And second is, should we propose that 50% of the time should be clinical, and it is not? Right now you have to have a didactic lecture, 8 to 9, 12 to 1, 2 to 4, and we have 70% time on didactic teaching and maybe 22.5 hours of clinical throughout the teaching. If you make 4 hours, 4.5 hours of clinical, Dr. Oja, are you around? Maybe we can, if you sit in the center, we could see your reactions also. And 4.5 hours of clinical and 4.5 hours of didactic. And I also would like Dr. Seth and others to comment, please.
Sir, just what I observed that uh, the system of medical education that needs a dramatically the changes in the curriculum, in the teaching tool. Like in management, we say management by walking. Even in the teaching also, whether it is a undergraduate teaching or postgraduate teaching, the teacher while going to the hospital rounds or maybe actually taking a detail, they have to sit over there, discuss. Though
Just
it was
give
being
us
practiced.
one line suggestion, Shakti. What do you suggest?
I will suggest number one, the problem-based learning actually that is very important actually.
No, not the problem. You say the solution now. We need the solution.
The solution is that actually we must adopt integrated learning modules. Actually.
Integrated learning module.
modules is
Who
very
will
important.
make?
Actually.
Who will make?
Sir, actually, like in our department, we made actually that module.
No, for
actually
the
and implemented.
country, integrative learning module is a very attractive term. But who is going to understand? In the whole medical education is integrative. So integrative learning module is a good idea, but I think reality is challenging.
Second important is the integration of the allied subjects. That is a vertical and horizontal integration of the subjects. For example, when we are talking about the anatomy, we should simultaneously talk about the surgery and other allied surgical disciplines.
Applied anatomy, applied, that has gone away somehow. It is gone away.
But that is a very important to like.
Very important that the basic sciences should have applied. I think if it is being recorded, it will be very good and must.
And then, sir,
That is, sorry, can I interrupt here, sir? I think this is already well taken care of in the new competency-based medical education syllabus of the National Medical Commission. Vertical and horizontal integration has already been very well explained, and now it is already enforced. Colleges are doing probably same thing must be there in the aims. So that is already in action.
Actually, but in practicality, actually, that at the district level, actually, or where a new medical teacher, this medical colleges are coming, hardly it is being practiced. That traditional system is still going on. Actually, we need to actually come out of that traditional system.
When we are talking of the modular system and then we're talking of applied and integrating, then there's a conflict between the two. On one side, you're saying you learn this, forget, you won't be asking you about that later on. And at that point of time, you will only be asking that particular thing. So integration to khatam ho gaya uska. You have to have the integration has to be applied the way we are talking. You talk about the applied. We cannot have modular system. That's what I don't feel the modular system is only for the engineering where they have to teach one module and then whether they learned or not, the least concerned later on. So,
The answer was to going to the private coaching colleges starting from second MBBS to prepare for the final. Coaching colleges will not give you clinical examination. They will just give you MCQs. So the idea was that how do you get the people in the class and not in the coaching class? And to that end, I think either we change the MCQ system, it is not easy. And therefore, I think we should have, in my mind, close that, but you keep learning. but your clinical part can become 50% of the total time taught. Yes.
Sir, I like to
Every
submit.
time I would request people to identify, so when you record, it is recorded with your name.
Okay. So I'm Dr. Saurabh Vashne from AIMS Devgar. Sir, medical education is a dynamic science. We accept like medical science. Sir, we have to move ahead as per the need of the time. Sir, innovations are very much required in teaching learning, as was being mentioned by my colleague. Sir, self-learning, active learning is to be practiced among the students because, sir, we have multiple source for them for learning. It's not what only we teach, they are supposed to learn. So we should be open to this idea that self-learning, active learning should be a component of teaching learning.
Very important. There are so many students. Are there students? Raise hands. Are there any student? You are also a student. But any undergraduate students are there?
Yes.
What is your thought as an undergraduate student? Are you doing self-learning? And do you understand the concept of self-learning? Please quickly, don't waste time. We have very limited time.
Sir, I'm a postgraduate student, but as an undergraduate, initially I found it very difficult coming from 12th standard to be introduced directly to anatomy physiology. And it took a lot of while for me to process why am I learning maybe the size of kidneys this much unless I knew how it is clinically relevant.
Very
So
important. Can I request all the students to come in the second and third row quickly? Run and come. Hurry up. All of you, we need you to tell us, is the system good or bad? Very
So in the
rapidly.
meantime, can I say something, sir?
Oh yeah, please.
Just in the meantime, as they're coming, we did a Chintan Shivir in AIMS Rishikesh about medical education, and we included students in that. And the students came up with very good suggestions, and they were mainly first professional and the second professional students. And some of the things which they said were, like you said, that initial part may be didactic lectures, which they called as spoon feeding. And then they said that after that, they should be left alone and they should be allowed to learn themselves, and the teachers should be there to moderate their sessions, like a flipped classroom type of technology. And another thing which they said was that they really hated PowerPoints and they wanted the teachers to be interactive during the class. And they even said that chalk and board or whiteboard and pencil would be a much better idea.
So one last comment, sir, before I like to. Sir, when we talk about evidence-based in all the fields, unfortunately, we do not have much research in the teaching learning methodologies in the country that what are the end users' requirement. So we only talk from our platforms. I think, sir, more research is required in the teaching learning for undergraduate and postgraduate students. That is evidence-based, then only we can say what actually is required.
More research on teaching and learning. Any other student brave enough, come and tell us. You will change the way you want to learn. Anyone else? I'm disappointed. Yeah, run to the mic. You all have sports shoes. Go ahead. Spring.
Sir, as far as self-directed learning is
You are a
concerned,
UG or PG?
UG, sir.
UG, oh,
Yes.
fantastic.
As far as self-directed learning is concerned, I don't think putting a few students in a classroom and telling them to learn themselves is getting anyone anywhere. And as far as classes are concerned, I think as far as the students are able to learn, maybe on their own, maybe with your help, if they're able to pass their exams, if they're showing the knowledge and aptitude, apart from clinicals, attendance should be compulsory, but other places, I think as far as student is concerned, if he's able to learn, he should be allowed to learn. He
That's
should
a
not be
very good
forced into
point. So
classrooms.
you prepare only for exams. Is that correct?
No, sir. As far as clinical skills are concerned, I think
You want to be a good doctor or you want to pass MBBS?
as a clinician,
You want
we
to be
need
a
your help.
clinician?
Yes.
And as well as pass the exam.
Yes. But when the student is getting the required knowledge, however else is getting it.
So there is a problem. This PowerPoint should be banned. That is a very good important point. And second, It is the don't put them into a class and do self learning. You be there mentally and physically. These are two very important points that we have. I want other feedbacks from students. There are so many. Each one you have to ask a question. Get up. Get up and ask a question. How do you want to change? Anyone else? No. Yeah, there is one more. I'm just trying to instigate you so that you give your peace of mind. Please, quickly.
So one of our professors of gastroenterology, while he was taking a MBBS class, he had asked them, "What are you reading from? What do you read?" So they said they read from Marrow. Marrow is a program which they read, and it's a program which prepares them for PG evaluation, like PG exam. And this particular, and they say that this is good enough for us to pass the exam, the MBBS, which is mostly
It's a good
MCQ.
program and they teach very well.
Yeah.
So I am not aware, but the way the world is, that you don't need teachers now. You have programs. But who will teach you? The reason for starting Navigate Medico CME was that you give skills. For example, there is a kind of ataxia, or there is a, so Padma would teach you what kind of, more musculoskeletal disorder. So the idea was that you have skills only onto the Navigate Medico CME, but that doesn't change the education. Dr. Abhijat?
Sir, one comment, Sir, Dr. Kuldeep here. Yeah, so just I would like to add comment about that is there is a curriculum which is known as hidden curriculum, which is not being designed by the educationist, but it is being followed by the students. And that hidden curriculum is the peer learning. And most of the time they are inspired by their peers how to compete with each other. And then they are learning from the exam system. That is how the exams is being conducted. So they devote all their energy for the for passing these exams only, and that's why there is a need for change in our system of education. We have to define our hidden curriculum, and also this should be included in our regular curriculum also.
I think 1 year in the first year is sufficient, or we need more time. 1 year
In fact,
physiology, biochemistry, I feel it's
yeah,
too packed.
In
Should
fact,
be minimum 15 months.
yeah,
Settling
in fact,
down as this
yeah,
girl
in
said,
fact,
you're doing PG.
yes,
You're trying to cope up with so many. And of course, as teachers, you define. You have a problem. Ask questions after your find 5 lectures. Today you're going to have assessment. NMC gives you a lot of freedom to work within that time, a number of hours for us. You give there, but again, as Sir said that about integrative learning modules, you have to teach the teachers to make them. You have to start at that level. And it has to be small groups go to their institution in place of calling them in a sense.
Very quickly. So are we relevant? Any more points on this? So we have done UG, PG. In my opinion, the reason for this is under the UG program in the US, now it is mandatory that you do 40 hours of artificial intelligence. Nobody will get the undergraduate degree unless you have done 40 hours of artificial intelligence. So my thought and my question to you is, are we ready to be relevant to rest of the world? There is no AI training, teaching mandatory in the, so I would say, how many of you as the UGs or now PGs would like 40 hours of teaching of AI in the undergraduate program? Those who think it is worthwhile can raise hands.
Sir, should I make just
Yeah,
one
just
point?
1 second, sir. So we see many, many hands. So please raise hands higher up. Okay, the house is almost 60% suggests, may not be all. So in my opinion, and I would like this to be considered, that it should start, AI should start from the UG level and at least 40 hours is spread out over the next. And machine learning and AI should become integral part of our learning programs. Yes, Saurabh.
Just one point I wanted
Yeah,
to
oh,
make,
sorry.
sir. what we learned in our time was largely based on voluminous style, that you get exposed to too many patients, treat too many patients, learn yourself. Now, these days you can't learn in this way. The patients are not like the previous style, that you do mistake and you learn from them. Structured teaching is the most important way of teaching. And we should, now structured teaching is not that it's a less volume, it's an optimum volume. So optimum volume based structured teaching is the best methodology which will help us. Rather, what happens, there is a quiz, because that's the another reason why people wants to do MDMS more than DNB, because in MDMS this is cutting practice बहुत मिलता है, ये बहुत मिलता है, but it's not like that. That era is gone now. That era is
So
gone.
your
We need a
point
structured
is
teaching.
structured teaching, and that I hope is already there, I think, but we may pay more attention to structured teaching. Okay, Shakti.
Sir, one beside actually the reforms in curriculum and other content, actually, I think there is a need for faculty development, which is very important.
Need for
faculty development, sir. Actually.
faculty development. Yeah, we were
it is-
privileged. 2010
Yeah.
we started,
And
but
it is
people
still
are
actually
not
now.
interested in their development.
But this is very important. It is a low cost.
I
also,
know
actually.
you can't get promotion, but I have seen the programs and they just are there for the sake of attendance. There is no penalty because this is not a 360-degree review. Students are not allowed to assess their teachers, which is mandatory. And therefore, the faculty development program is as of now, correct me, sir, is unilateral. You tell them that you should be there, but no assessment by students that these teachers have become eligible. What do you say?
Actually, sir, what we did actually, we started this faculty development in AIMS Jammu, and attendance was 100%, and we invited from diverse fields, not only from the clinical aspects, actually from diverse.
Would you
fields.
involve the students in assessing teachers? Yes or no?
Yeah, that should also be there.
Is that a
actually.
good idea?
Is it required? Actually?
Should this become
Yes.
mandatory that students anonymously assess the teachers? Are you students happy with this? Say loudly, yes or no? Yes.
Yes.
If you don't like a teacher, he should come prepared. He can't do anything else. It's your time. You have 1440 hours of learning in medical school. Every hour must be used and educated.
Sir, I have a fundamental question. 9 people are on the dais, and large number of teachers I see here. Honestly, tell me what you read in your undergraduate medical curriculum. Was 1/3 of it not waste? How much ophthalmology is being used by a gynecologist? How much mental health, all of you who are sitting on the dais, those days have left in choice? It's a question. Most of the people of my generation and 20 years later have left many of things in choice. हमें तो इतने क्वेश्चन करने हैं और उसमें ये अगर नहीं भी पढ़ेंगे तो चल जाएगा काम. So should we not seriously think about reorganization of the medical education, and why do we start specialization at the end of 5.5 years, 6 years? Why not earlier? An engineer, if can opt in the 3rd year, what area he has to specialize, why not a medical graduate? It's a question which is fundamental question. I have, as a member of the Medical Council of India, I raised this question then, but the lobbying is tremendous. Every discipline is lobbying for its own development. Should we holistically think about it?
Dr. Gautam sir, point is well taken. When the new curriculum was designed in 2010, it was what is must know, what is should know, and what can be known. And these were the 3 parameters. And the size of the teaching program was substantially reduced. But every time people want to add on, And this exercise is a dynamic, must know, should know, and can know. And I think we should go back to this. But point is well taken. Yes. Yes, sir. Sir, use a mic, sir. And yeah.
What I feel that actually there is a need to revisit the duration of the courses actually. MBBS, 5.5 years, whether we have to go for that.
The
or maybe
course in
reduce it.
my mind should be 4 years.
4 years, yes.
And this was proposed in 2010, but was, vetoed out because in the US, the courses were 6 years. So we said 4 years is good, 1 year of internship. So you are at par with the IITs and engineering schools because every year extra studied, you should give one more. So we in fact proposed to that the UPSC, when you admit an engineer for a service or a doctor, since doctor has read 1 year more, should give one increment without asking. It didn't implement. So it should be 4 years and the course should be, kind of scaled down. I agree with you.
Even in fourth year, actually, the candidate must know where he wants to go, surgical
Yeah.
discipline or medical discipline. Why analysis?
All right.
The
So now
internship-
these are suggestions, but we have to have, are we relevant on this?
So regarding 4 years, sir, I would like to say that when we compare with the US, so they have a 4 years of undergraduation also. So we intake these students directly from
The point is well taken. 4 years is a debatable issue, but if you see in the life of an individual, why doctors should suffer more and read more? 11.5 years for your UG, PG, DM, MCH.
I agree with the 4 years also, because this is very important, 4 years. But again, for the entrance also, there should be 2 years should be given
Oh, yeah.
for exploring the domain of the medicine, because they come directly from
Let's
the
hear
schools.
from the students. Do you want 4 years course or you want 4.5 years? What do you say? Those who favor 4 years can raise hands.
They cannot tell.
Students are not aware of 4.5
Sir,
years.
one point here, what we are actually aiming, whether we are competing like you are comparing with the IS and like this, we will be competing 4 years, or we are serving to the people expectations
Yeah.
is that. Because the both are contradictory.
You are
When
absolutely.
one point, sir,
Let-
one point. And another thing, this is the when we are discussing the medical education, there is the gradation of our medical colleges. We cannot compare like medical undergraduate in INI and in the district hospital, district medical college.
I'm not
That-
saying it decrease to 4.5 to 4. I'm saying if it is possible, if not, the government should give one more increment, one more level of salary to people. It is the number of years you have studied. So
Yeah.
there are two ways. One, either decrease the course to 4, which is in my mind is better, younger doctors and the experience, or give one increment or two increment for every single year of extra study. This is important. We
May
have
I-
to move quickly to
May
now.
I comment, please?
Yes, sir.
Sorry. Now the question about these 4 years, 5 years, these, that, they are all debatable and there are infinite arguments will come in favor and against that. What I feel is that we have to undergo the process of philosophy of education. And the philosophy of education is that the teacher's role is teaching the process of learning and not that information passing. Now we have enough information available in the every platform, and best textbooks are available, which can never replace just a classroom reading of a textbook. So the role of a teacher has to teach the process of learning rather than just
Very
passing on the
important.
information.
It is not information passing, it is process of learning. This is a revolutionary step, and we all, including the NMC, should now standardize the process of learning and not PowerPoint or information passing. Well, yes.
It's
Sir,
very good
uh,
affirmative.
the student will try to learn what the way he is going to be assessed. So we have to improve our assessment. अगर आप उसको MCQ ही दिखा देंगे
So we have to have more analytic analysis, analytic examinations. Then he will start analytic teaching. So, I mean, one line if you want, it should be a project-based learning from the day one, and integrative learning from the basic and applied, that should be there. There's no doubt about that. But there should be project-based learning and patient-centered learning rather than the class learning.
Very important point, Puri Sahib. And if you see the Vision 2050 document, for getting into your postgraduate, 50% marks were for the final MB, 50% is at the end of the internship. And those were questions, all questions of that 50% marks were clinical based, although done by computer. But you have a patient coming to the emergency room, here is the blood pressure, ECG, what will you do? So all questions were prepared and should be clinical based. And at the end of the internship, this exam occurs. You have to pass the clinical and the 50% in the final MB. The collective goes you to the MD-MS program. Yes, sir.
So just I wanted to end when we're talking about the reforms.
So is this okay with that the educational reform, the assessment of the students is clinical and this should be done? If that is the way students would learn, assess, their learning will improve. Is that okay? So let that be one part. You all agree on that?
Yes, sir.
Those who agree on the assessment of this type, raise hands, please. Oh, 100% nearly. So, Oja Saab, for you and for sir, the assessment process must be 50% clinical, 50% theory. Thank you.
Sir, may I give my thoughts?
Madam
I'm
Churamani,
Dr.
very
Churamani
brief,
Gopal.
madam. Any innovative points?
See, most of the time we are focusing about how the student should learn best. Nowadays, people are learning for, when they are undergraduate, they are trying to learn for the postgraduate examination and not really focusing on the learning. So this question of integrating internship 50% and giving the examination later on is a very welcome stand. But I would also like to revisit the authorities how should the student be taken for post graduation.
Yeah. So how do you think you should take?
I would suggest that 50% intake of the students should be in that own institution, merit wise.
Yeah, it's not
The other
possible.
50% should go for NEET examination. There are reasons for this. Firstly, this will promote.
All right. So the question is, can 50% students get into the same institute? To me, it's being a national entrance. So your suggestion is well taken, but madam, it will be parked. It will not sail or fly. Sorry. We need to move forward with all apologies in the interest of time. We would have comments from there. I also would like to say we have two more quick sessions: collaboration, innovative culture, and good governance. But UG, PG, anything else, Saurabh?
So just one addition, sir. Sir, during COVID, we have learned. So, sir, in our institute, I will share, sir, we have
No,
added,
suggestion.
Sir, one module of digital health should
Oh
be
yeah, that is
important
a digital health
undergraduate
module
curriculum,
is
sir.
agreed
Undergraduate
upon.
curriculum.
All those who agree can raise hand. Digital module of health. All right. So we all agree on this. So all those points where we agree can be the writing points
Then
for
one more,
these.
every department must have a mod, how they're going to do formative assessment, because that is going to be given a lot of emphasis for their final evaluation.
So formative assessment, very important, and this every department should prepare. Now we have.
Sir, I want to talk on.
Yes.
Myself, Dr. B.L. Soni, Assistant Professor, AIMS Bhopal. Sir, I want
भाई
to add.
लाइट्स पूरी कर दो यार हॉल में थोड़ी लाइट्स बढ़ाओ जरा शक्ल नहीं दिख रही.
Sir, you taken point. The curriculum should be 50% clinical and learning should be 50% clinical and 50% theoretical. So ideally, we should have to, as per the NEET exam, when PG exam is going, that should be ideally in this module only.
तो यही तो
Because
नीट का एग्जाम जो है ना, एग्जिट वाला एग्जाम, the exit exam must have 50% clinical assessment. You know, लोगों को IV line नहीं लगाती, DM में आ जाते हैं. They have not used an IV line in their MD exam.
नहीं, not only sir exit exam, बाकी PG का जो theory exam होता है उसमें भी सर ऐसा कर देना चाहिए, so that
तो यार
तभी
तुम बनाओगे कुछ मॉड्यूल, तुम तो असिस्टेंट प्रोफेसर हो,
बिल्कुल सर, बिल्कुल बिल्कुल
यू
सर,
विल हेल्प इंटीग्रेटिव केयर के मॉड्यूल में हेल्प करोगे?
यस यस सर, 100% सर.
प्रिपेयर
और
एंड सेंड
एक
इट टू डॉक्टर पुरी एंड डॉक्टर
सर
कुलदीप.
कंपलसरी कर दो सर, एक्चुअली
Compulsory.
फैकल्टी को कंपलसरी कर दो कि ये आपको मॉड्यूल बनाना ही है. और सेकंड थिंग सर, लाइक IIT एंड अदर IIM कॉलेज, वी शुड आल्सो क्रिएट सम डिजिटल platform, open platform, free platform, so every student of medical student can use that platform, that lecture on particular topic, because the most of topic the
I
teacher,
will go one step further. Every student must prepare an integrative care module by himself.
Yes,
Every student should be encouraged that they should submit a module of what do they want? Let the dream come from them. And of
But-
course,
but sir, it should be
faculty
peer
mandatory.
review. Yes sir, faculty mandatory.
Faculty mandatory,
Yes, sir.
students recommendatory, at least once or two modules during their training of integrative care module. Is that correct? Is
Yes,
that
sir.
a good idea?
Yes sir.
So we have experimented on this. We have a AIMS Rishikesh Digital Academy on which students as well as teachers are putting on their modules, and they are available for everyone to see.
So AIMS Rishikesh is leading in this. I am sure other AIMS are also doing some. If not,
Yes,
this
sir.
module can be considered for sharing an experience, and maybe you can do a one-day workshop or a symposia under NMS. NAMS and Barasa would be considering this request that we can have one day of digital learning modules from AIMS Rishikesh to all the INIs and NAMS fellows. Is that a good idea?
Yes, sir. Yes.
All
Sir,
right.
second thing, sir, you told 40 hours is compulsory for AI. That is good, sir. Fundamental AI should be no. But before AI, the most lacking thing in UZ, particular the research and innovations, IPR particular. In Japan, the IPR was read in 5th class and there is textbook in 10th class. So I think why not at least UZ level we should know IPR, intellectual property rights and innovation things and research. Make it compulsory in curriculum.
What is
sir.
your name again?
Sir, Dr. B.L. Soni from Assistant Professor.
BS?
B.L. Soni.
BL Soni. Are you a associate fellow of the academy?
I am only MEMS member of.
NAMS
Yes,
member?
Yes.
Member.
Yes, sir.
So we are privileged. A big round of applause.
Thank you, sir. Thank you, sir.
Soni sir, you have done a lot. I take all your suggestions. IPR should be taught to the students
Yes,
from
sir.
beginning, not after you pass out.
Yes,
Very
sir.
good idea.
Yes, sir.
The care module you have said, and digital, what you are saying is extremely important for us. All your suggestions are valid. Anyone else who is there?
Thank you, sir. Thank you, sir.
New ideas? So many are sitting. One thing I want to say about research, currently research is imposed upon the student. The guide says, ye wala kaam kar lo. No creativity from the bottom. I think we should encourage the students should be asked, at least I asked to bring 15 questions. What do you want to do? Many of them they can't, but at least they start thinking. Don't impose, but that's not a suggestion which can be implemented. Now we have Shakti, your sessions, sir, were on modules, health economics, health administration. Well, these are partly covered, but if you have something more, and your panel includes Dr. Vikas Bhatia and Lieutenant General Ashok Jindal, are they around? Dr. Vikas Bhatia is not there. So anything else you would like to add, Dr. Shakti, on your outreach services or anything else? Please use your mic, sir.
Like in outreach services is mandatory. Actually, we have already.
Which services?
Outreach.
Outreach.
Services. This is very important. Actually, we have already got approved one proposal for outreach services in one of the 100 kilometer away from our campus. And then we are going to establish that actually so that we can post our doctors, nurses, and students 3 months
So
posting.
do
over
we
there.
have a module, Oja Sahab, of outreach services or village posting kind of thing? Sorry?
Undergraduate, you're telling.
At undergraduate level.
Undergraduate level, I am not exactly detailed about the things. I am not aware of it.
Kuldeep, are you aware?
Family adoption program and all the things are there, but
It used to be, at
Yes,
least
sir.
in our time, we
Sir,
were
there-
posted.
there-
Just a minute, sir. Kuldeep.
Yes, sir. There are outreach programs starting from first year. They are exposed to the community medicine, and second year onward, they go to the community also.
There are outreach programs already.
And
Sanjeev
also
says
there is
already there.
so there is a family adoption program in which they are
Family
connected to their family.
adoption program.
That is there actually, but
Huh?
community outreach program.
Sorry,
so that-
please use your mic.
Sir, we actually what we are going for that at establishing a full-time 24/7 with teleconsultation, a community program where actually it has been approved by our governing body, where our faculty.
No, but that
resident
is
will
a
be posted.
service. But what do the UG, PG
Yes,
program?
already they're going in the rural areas.
So under the training program, it
Yeah.
is not. But what you want to say is that this should be by a hospital service or
Institute can
institute
take over that
service.
and develop as a role model.
Sanjeev.
Sir,
Posting in the district hospital.
absolutely.
First, second, third year of your postgraduate. In 3 months of time, you can do in the first year, or you can do it at a bed.
That is a good suggestion. Yes,
And
sir.
also, sir,
It is not incorporated. It is incorporated.
see,
sir.
the internship program is 3 months at the rural level, mandatory in all the medical colleges. And
All
it
right,
was primarily started for this purpose.
So we already have it.
We have it, sir.
So we nothing more added.
one more thing I would like
Oja
to
sir,
add.
yes.
One more thing I would like to add at completion, Zach, about the next. The once the next come, which we didn't debate all throughout. Next is a mandate as per the NMC Act, and we should have started within 3 years, but we have not been able to do for various reasons. It will be necessary that the elite class of this profession should insist upon the starting of the next as early as possible. And once the next comes, many of these problems about the internship, not students not studying, will be solved, because next will be over in the end of the final MBBS, and the students will take part properly in the internship training. In this, regarding the next, we had a series of discussions with Niti Aayog, and it was also one of the suggestion was there that for preparation for the next, we will have a 2 intermediate exam, which will be an optional exam. During this 4.5 years, they will have 2 exams which will be conducted by the university, but it will be an optional. It will not be a compulsory, which will help the students to prepare for the next, and this will solve the problems of the thing. Not going to clinics will be in the internship.
Thank you. The question was quality clinical services, outreach services. We already know that during the internship there is 3 months this thing. But I want to stress one thing: adopting the hospitals around as a big brother, hand holding, that is essential. Then have the program of your MD or MS students going there as 3 monthly as is being suggested, not during the internship, but during the MDMS. That will improve the exposure as well as improve the setups peripherally also, because there will be an exchange of ideas and knowledge between the bigger institutes and the smaller institutes around. And when we have 26 aims and every district has got a medical college, then each medical college adopting one civil hospital or anything.
Thank you. I just want
Not only the community medicine, please. Everything. I mean, all the residents, MD or MS, should be rotating there 1 month, 2 month, 3 month. And I will go a step further. That it should be we are giving academic leaves and so many leaves to our faculty. Each faculty should be mandatory to spend a week at these hospitals. That should be made mandatory. Even
good idea. So faculty, I want to comment on Dr. Oja's. When he was first person along with all of us, next should happen, the only very gold standard of an Indian medical education. I humbly invite you to request have two parts, one at the level, one at the end of the exam. People are not, they are not make sure clinical part gives 50% marks at 50%, then only next. Otherwise, they will be preparing for second. Yes, yes.
We totally agree with you that next will be very important, and we've always been looking forward to it so that students don't have to spend that extra energy on preparing for their exams, which are being coached for and other things. So this is really needed, and this will save a lot of money and extra expenditure on those coaching classes, etc., which are happening. And two steps is also very good because at the end of internship, they can learn the skills, and those skills can be tested, which is very important because people coming to MD and they
That
don't
time,
have.
560
Yeah.
skills were listed out as the
Yes, sir.
having. And we have two more things. Dr. Bhairasa, while you around,
This-
you are part of the last part of good governance in medical education, models for leadership. Dr. Oja is supposed to, that is not under conflict. Oja join there or from there.
Can
No,
I
no, I
take
have
one
already
point?
covered the governance part in my
Good
talk. That's why.
governance in medical education. Like to add
So since it's mentioned about health economics and health administration, the transition of how we can apply that, we can have, because and evidence-based medicine is also being talked of now in the undergraduate years. So we have a cell or a center for evidence synthesis and public policy, and also an area for implementation research, because all these things which we are talking about will not see the light of the day if they're not implemented.
Now my last 5 minutes, I want 5 students to get up. Your comment. Starting from the fourth. Just get up and just come over and start saying things what you have listened to something and identify which class, which UG or PG are you.
Good afternoon, all sir and ma'am. I'm first year BSc nursing student.
Nursing.
Yes.
That's all right. Doesn't matter. Tell us.
I thought that PowerPoint should be banned and
Should be banned.
classical learning should be there because we are more interested in learning from the blackboard and the chalk, and the teacher are teaching us because.
All right, next person, no PowerPoints. What do you say?
My name is Nancy Chaudhary. I'm also from first year BSc nursing, and our clinicals are already started, and we experience that we learn better in hospitals rather than in classrooms.
Next person, hospital.
Good afternoon, sir and ma'am. I am also BSc nursing student first year. My name is Manisha Nagora, and I think also that clinicals are more important than the.
Any, yeah, last person there.
Good afternoon, all. I'm also a BSc Nursing first year student. Like, I feel that, like, I